All right. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It's been a morning. It is Sunday, March 30th, 2025, and it is time for another live IC support group meeting. My purpose in doing these meetings is to make you so strong, knowledgeable, informed that no one can mess with you again. I don't want anybody telling you that this is all in your head. I don't want anybody telling you that you're damaged goods. I don't want your self-esteem to be affected by this because you are not your pain. You are a human who deserves to be here. You have a role in your family. You have a role in your city. You have a role in your community. You have a role in your church. And our job is to help you get back into that role. Now, I am live streaming right now. Hi, Ann, on YouTube and Facebook. YouTube, guys, I need you to understand YouTube's being very, very unstable. And for the last two meetings, it's just stopped streaming. I mean, I'm streaming on my end. The connection, it's not even the connection, it's YouTube itself that's messing up. And so if I lose you or you lose me on YouTube, come on over to our Facebook channel. I wish I could tell you what the problem is. I do not know what the problem is. Hi, Curtis. Hi, Kim. Hi, James. James says, you guys, when I'm looking here, I'm looking at Facebook, and when I'm looking here, I'm looking at YouTube. James, this is great. He says, I don't know if you remember me. I just wanted to let you know I've been feeling a lot better recently. Thank you for all the work you do. Awesome. You are why I do these meetings. Because number one, we want to give you information that's helpful. And number two, we want your story to inspire others, and we want to learn from your story. And on that count, I have started putting up patient stories. I'm putting up more patient stories. I've got about 6 or 7 filmed that are me talking about patients. And I'm going to start the Zoom interviews with some patients so that you can share your stories directly. Because I think ultimately, the more people you meet, the better. The more people you meet, the better. You can see yourself in other people. You can see that there's hope. You can see that there's encouragement and that you're not alone. You know, we just don't want you to be alone. Now, I will say it's a very, very stormy day here in California. Who knows what's going to happen? If I disappear suddenly, that just means the power's out. It's just one of those days, my friends. It's one of those days. Normally when I do these meetings, I do a little 30-minute intro, and then I will take your questions. Today, we are going to talk about bladder installations, but before I do that, I have a product reveal to share with you. This is very, very exciting. Okay, hold on. I'm going to do it right. Okay. So y'all know that the most well-known supplement for IC out there is Pre-Leaf. It's been around for like 40 years. Pre-Leaf has sponsored IC events around the country. They have sponsored the IC network. You see them on the back shelf because they're sponsoring this meeting, and they have for years. I've worked with them for 30 years. So incredibly grateful for first AK Pharma and Alan Kligerman, the gentleman who invented Pre-Leaf. He also invented Lactaid, Beano, lots of things. Brilliant scientists. Well, guess what? They have their first new product in years, and it's called P-Leaf. You know what this is, my friends? Palmitoyl ethanolamide. This is to be a companion to their Pre-Leaf product line. So as they say here, introducing P-Leaf from the makers of Pre-Leaf, the brand trusted for almost 30 years to reduce up to 95% of the acid in trigger foods and beverages. Now P-Leaf is a companion product and provides daily supplementation to support ongoing bladder and urinary health through its 2 hardworking ingredients, PEA and polydatin. PEA is naturally occurring in the body, and research indicates it plays a role in helping to manage bladder and pelvic discomfort. Polydatin helps with antioxidants to help maintain a healthy inflammatory response. Pea leaf contains the ingredient and dosage combination of PEA and polydatin that was clinically shown to reduce significant bladder and pelvic discomfort and support urinary and bladder health. So if you struggle with pelvic discomfort, try the calming urinary health support of pea leaf and get the peace of mind that comes from knowing that our clinically tested ingredient combination has been shown to be safe and effective. Super, super, super exciting. So in 2019, the PEAIC study came out that showed that 87% of patients showed a significant reduction in their pain and discomfort. Pea leaf has now become a cornerstone, or palmitoyl ethanolamide has become a cornerstone of IC therapy in Italy and in Europe, where they did the original studies. Of course, we have Peora. We've been working with that now for 3 to 4 years, but it's always good to have another option. And I love the fact that this is going to be a companion to Pre-Leaf. So P-Leaf is now available on Amazon. So congratulations, DSC Healthcare Solution, for looking at yet more innovative ideas that will help reduce the discomfort of patients who have bladder and pelvic pain. On that note, I will say that if you go to the front page of the IC Network website, icnetwork.org, I do have a new updated blog on PEA, which shows yet more research helping pelvic pain. So we have studies with IC, we have studies with chronic prostatitis, chronic pelvic pain, many, many more. And we have a new study showing that it can be helpful with menstrual cramps. So super, super, super exciting. All right. Hey, Donna. Anne says, I'm taking macrobid for an E. coli infection. I want to test again for how long? How long should I wait? 10 days to 2 weeks, I would think, but see what your doctor says. Hello, Curtis. Hello, Kim. All right. Now, you guys on Facebook, you're being a little bit on the slow side, my friend. I need you to post so that I can make sure that the commenting is working. I am not sure if it's working or not. So if you could say hi, I would really, really appreciate it, because you just never know these days. All right. So I want to share a very, very interesting story of a patient that I worked with just after last Monday, as a matter of fact, after our last support group meeting. Oh, Mira says it's working. Hello, Carol. Awesome. So I had an IC patient call me. Hi, Lori. Hi, Natasha, who was looking for insight into lactoferrin in particular. She had read some stuff online. She was in some of the groups on Facebook, was very confused, wasn't sure what to do next, getting a lot of mixed messages. And of course, I love the chance to talk with patients who are confused, because we can try to give them a little bit of context. Her story was sadly predictable, but also kind of shocking in a way, because this was somebody who was diagnosed with IC like 20 years ago. And she was operating on the assumption that she had an incurable bladder disease. And yet they looked in her bladder with a hydrodistension, perfectly normal bladder, nothing physically wrong with her bladder. And yet her doctor told her 20 years ago, you need to do bladder installations. And she has been doing home bladder installations twice a day for her IC, like a rescue installation. And because they weren't working, she was taking oral meds. She was taking, like the antidepressants and things like that, the antihistamines. And she was really loaded up on supplements. She was taking a lot of aloe, a lot of this, a lot of that. I can't even imagine what her monthly medical bill is. Massive, massive, unsustainable. And I asked her, I said, okay, Have you read anything on IC recently? And her answer was no. She just comes onto social media. Huge mistake. Guys, you got to read. You got to be at least come to the meeting so I can give you some of this new information. And I started talking about the phenotypes. She's like, never heard of that. She'd never heard that there were distinct groups. She just thought that she had an incurable bladder disease this whole time. And we kind of go through these groups. Normal bladder. Her symptoms have recently gotten a little bit worse, which I think was due to estrogen atrophy more than anything else, because she's now in her 50s. Never had a pelvic floor assessment. Had very clear symptoms of a pudendal neuralgia. Pain with sitting, gets better with standing. And I asked her, I said, again, have you had a pelvic floor assessment? She said, no. What's that? Do you know about the pelvic floor muscles? No. What's that? Go through the whole thing with her. And then at the end of this conversation, she shares that she's doing bladder installations twice a day. And I'm like going, what? What? You've been doing bladder installations twice a day for 20 years? Are you better? And she goes, yeah, they help. And I went, no. Wait a second. If you're better, then why do you keep increasing this and this and this? And why are you adding this? And why are you adding this? Are the bladder installations truly helping? Are they fixing the underlying problem? And she said, oh, no. Good point. And as we're kind of, talking with IC patients is like kind of finding a needle in a haystack in a way, and trying to understand motivations behind why we're doing this and why we're doing that. And it's like, okay, who told you to do bladder installations? My doctor. Okay. But you have a normal bladder. And she's like, yeah, I did. And it's like, how does that make sense? And she's like, I don't know. It's just what he told me to do. And in 20 years, she'd never challenged that. She just kept doing them. And then come to find out, her doctor, her urologist, was actually elderly 20 years ago. So we're talking old school, old school. Probably hadn't been to an IC conference ever. Treating out IC out of a textbook. And that's my motivation for this meeting today, because we have to talk about bladder installations. It is important that you understand that in the old days, we all thought IC was an incurable bladder disease. In the old days, they thought that there was a defect in the bladder wall. That's all changed. In the old days, some of the first bladder installations ever used were silver nitrate and chlorpactin. These are strippers. The goal of these old therapies was to strip the bladder wall off completely with the hope that a new healthy bladder wall will grow. And the pain that patients went through when they had their bladder stripped 25, 30 years ago was agonizing. You must promise me never, ever let anybody put anything in your bladder without first telling you what it is. As an example, a couple of years ago, a patient called at her very first appointment, before she had even seen the urologist. The nurse said, hey, we need to get a urine sample. I want to do a catheterized urine sample. Are you okay with that? Patient said, yes, absolutely. Not a problem. And then a split second later, The nurse put something in her bladder that burned, and she started yelling, "Oh my God, what are you doing? What are you doing?" And the nurse like looks up like, "I'm giving you a bladder installation." It's like, wait, we didn't talk about this. What are you doing? And it was agonizingly painful for her. Can you imagine somebody giving you a treatment and not even telling you they're doing it, much less what it's supposed to do? She was livid, furious. She should have been, because there's something called informed consent. You know what? They're supposed to talk about the treatment beforehand and talk about the pros, cons, risk, benefits, and then you're supposed to agree to it before they do it. Now, what did they put in her bladder? I suspect they put an old bladder stripper in it. I don't know. She didn't know either. Another example was the wife of an active duty military gentleman who had IC. They admitted her to a hospital, Army hospital. This was like 5 years ago. And they gave her silver nitrate infusions over 3 days. She had 24-hour infusions of silver nitrate, a stripper in her bladder. They started at a low concentration. The next day, they got stronger. The third day, very, very strong. And he called me desperate for information. My wife is screaming. What are they doing to her? And I went, what are they doing? She goes, and he went, silver nitrate. I went, oh my God, we don't do that anymore. They're stripping her bladder. It's not even in the guidelines. Our guidelines don't even mention silver nitrate or chlorpactin. So it's still out there, my friends. I never heard from them again. I can't even begin to imagine how she suffered. So the next bladder installation that came out, or that was discovered, was DMSO. Now, DMSO, also known, the brand name's Rimso 50, has very, very mixed messaging. I did DMSO 8 times, did nothing for me. But of course, I always had a healthy bladder wall. So why would it help if I had a healthy bladder wall? The challenge with DMSO is we really don't know what it does. It has so many methods of action. Number one, it's a penetrant. It penetrates deeply into the bladder wall. Number two, it appears to cause like all the mast cells to release histamine at once, kind of cleans them out, which is why you can be in a lot of pain after DMSO, and maybe that helps for a short period of time afterwards. Maybe it has some anti-inflammatory effects, but our challenge with DMSO was research that came out from a researcher named C. Suba Packer, and this was back in the late 1990s, early 2000, who was able to prove that DMSO used at the FDA-approved dosage of 50% caused the bladder wall to spasm permanently. Not in everybody, but in some patients. It just caused a permanent bladder spasm. She did a dose response. She was using rabbit bladder, and she started at a very low dose, and then it got higher and higher and higher. 25% was fine. 30% was kind of fine. When you got up to 50%, the muscle went and it didn't release. And she presented that data to the American Urology Association annual meeting. I was there. I actually saw her research before I even got there. And I went to every single IC researcher there. And I said, so what do you think about the DMSO research? And they all went, pretty much all of them went, well, we don't really use it so much anymore. One doctor said, I think there's a place for it, but we really don't use it as much anymore. And again, like I did it myself. And then an amazing moment happened at that meeting when Ray Rackley of the Cleveland Clinic, who has long been considered one of the better IC clinicians in the United States, stood up and he just said, hey, we don't use it anymore. We believe it's responsible for the vast majority of bladder removals that we have to do because it damages the bladder wall. and it damages the bladder wall. And so we had this big discussion of IC researchers from the United States and Europe. Everybody's like, whoa, that's really saying it. But there was consensus at that meeting not to use it at the FDA approved dose of 50%, that you always do it in the form of a DMSO cocktail that brings the dosage down to 25%, which Ms. Suba Packer's research showed was safe. She came back the next year with another study, okay, which supported that original study. And so DMSO fell off the radar also. Just, I don't know, in my experience with the patients and doctors I'm using, it's really not used very often anymore. Another reason why it's not used as often is because it does cause some pretty significant side effects. Number one, you can ooze a garlic-like smell out of your pores for a day or two. Not the nicest thing in the world. Number two, it can hurt like hell. Like probably the biggest mistake I made in my IC therapy was trying to drive home from the doctor's office with DMSO in my bladder. Agonizing. And I always say now, listen, learn from my mistake. You don't want to get stuck in a traffic jam with DMSO in your bladder. You wait your 20 to 30 minutes at the doctor's office, you pee it out, then you drive home. Don't try to drive home with DMSO in your bladder. Mare says, me too. But then Robert Moldwin was one of the first doctors to start using what we call an anesthetic cocktail. So an anesthetic cocktail actually numbs the bladder wall. An anesthetic cocktail is diagnostic. So if you think the bladder wall is triggering your symptoms and you put lidocaine in the bladder and it makes the symptoms go away, then okay, we've now identified the bladder wall as one source of your pain. If it doesn't touch the bladder pain, then we know that, okay, it's not your bladder wall generating this pain, it's something else generating your pain, such as your pelvic floor or something else like that. So the anesthetic cocktail became fairly popular fairly quickly. And doctors were doing just lidocaine or just Marcaine. But then somebody created a rescue installation. And Melinda says Dr. Moldwin's been one of my doctors. He's a joy. He and his wife are an absolute joy. So then they combined lidocaine with heparin. And heparin acts to coat the bladder wall, while lidocaine acts to numb the nerves. And so it is indeed the rescue installation, which now is by far the most popular installation used around the world. Now, another thing that we ponder is if you have, for example, estrogen atrophy, and your bladder has thinned, your bladder lining has thinned, and it's becoming more vulnerable, then it makes sense that we could give your bladder a little bit of extra protection. And the way they do that is with something that will coat it like heparin. It's a coating. Or if you're in Europe, chondroitin, and that includes Canada too, that was called Urethral, or sodium hyaluronate, which is called, what was that called? Cystostat. So in Europe, but not in the United States, they were using other coatings. And that was interesting because the two companies were fighting each other and they were both trying to prove that their product was the best. And then somebody combined them together. A combination of chondroitin and hyaluronate together turned out to be even more successful. So that's called Ialurilla. That's not available in the US. That's in Canada and Europe. Okay. So today, the most popular supplement is, in fact, a bladder installation. But let's get back to the patient that I was talking about. Bladder installations for 20 years at home. Jo says she's doing Ialurilla bladder installations. Cool. Okay. This patient had been doing them for 20 years, twice a day. Did they help her? Maybe manage symptoms a little bit, but it certainly didn't fix anything. And more importantly, she kept having to add more and more and more and more to try to find some relief. And so in her case, clearly the bladder installations were doing nothing. They really were doing nothing other than maybe a little bit of symptom management. And that's really the role of a bladder installation today. Number one, we phenotype you. Okay. So do you have Hunner's lesions? Hunner's lesions, we know, are potentially caused by viral infections or ligament laxity. If you have a Hunner's lesion from a ligament that's messing with nerves, is a bladder installation going to help you? No. If you have a Hunner's lesion caused by a viral infection, is a bladder installation going to heal that lesion? No. It might chill it out, might numb it a little bit, make you feel better for a couple of days, but it's not going to fix it. If you have estrogen atrophy, is a bladder installation going to be helpful? Maybe, because it's going to coat the bladder and give your bladder a little bit of protection. But isn't it more important to do it naturally with estrogen? It doesn't make sense if you're an estrogen atrophy patient for you to focus on bladder installations and not working on improving the quality and health of your skin. The reason your bladder is vulnerable is because you are in estrogen atrophy. How do we fix estrogen atrophy? Not with a bladder installation. We fix it with topical estrogen. That's the single most important and effective therapy for estrogen atrophy. But will a bladder installation help control some of your symptoms? Sure. If your symptoms are being driven by a tight pelvic floor, as hers was, is a bladder installation going to help over the long term? No, really not. Because your muscles are the underlying problem. We got to work on muscles. Is a bladder installation going to help with pudendal neuralgia? Definitely not. Because pudendal neuralgia occurs when muscles are squeezing nerves, or when something else is squeezing nerves, or if a nerve is stuck in scar tissue. Is a bladder installation going to help the central nervous system for patients with widespread pain? I don't think so. Is it going to temporarily calm the nerves down in your bladder so that your bladder isn't poking your central nervous system? Maybe. Is it going to calm your central nervous system down? Is it going to turn that amygdala off that's driving a lot of these symptoms and a lot of fight or flight? No, it's not. So it's important that you differentiate between symptom management and underlying causation. Listen, if a bladder installation, so what's the perfect role for a bladder installation, in my opinion? A bladder wall flare. So let's say that you have been in an extended bladder wall flare for one reason or another. And no infection, but let's just say you're in severe estrogen atrophy and you started drinking coffee again and your bladder's screaming. Yes, Mary, it is live. A bladder installation is ideal, and it's in our flare management guide if your bladder wall flare is not responding to self-help. So number one, you've stopped the irritant. Number two, you've alkalinized your urine with pre-leaf or sodium bicarb. Number three, you've tried azo. Azo bladder pain relief tablets is not making a dent in it. You've been in pain for 3 to 4 to 5 days. You're tired of it. You call your doc and say, listen, I'm in a flare. I know what caused my flare. I screwed up with my food. Can I get a bladder instill? And in fact, Curtis Nickel up in Canada, who was the top IC doctor up in Canada and absolutely one of the best in the world, he just had installation clinics every Friday because he didn't want you to go into the weekend having a flare. So, in my opinion, the ideal role for a bladder installation is with a flare management. But again, getting back to the case study that I'm sharing, bladder installations for 20 years. And the part that I think frustrates me the most is that no doctor that she was seeing said, are they working? Do we really need to keep doing this? And thus, I'm going to ask you the same thing. If you're currently doing bladder installations, okay. If they were working, why are you going back and getting more? If they wear off after a couple of days, then okay, short-term gain, but what about long-term progress? We still have to be focused on what the underlying problem is to try to give you some long-term progress too. So Britt says here on Facebook, the bladder cocktails work for maybe an hour with me, then hurt like heck after that. No help for me at all. Yeah. Yeah. And the thing about it can either be the cocktail itself that they're using, or it could be just the fact that they're stretching the urethra every time they do it. And the first couple of times you pee after having a bladder installation is not fun. It hurts a lot. It hurts a lot. And the other big challenge is the fact that every time you put something in your urethra, you are increasing your risk of a UTI. So on the IC Network website, we have a big section on bladder installation, and I have all the published formulas that I have found. There are probably a couple more, but I think I have Rob Molden's formula, I have Lo Parsons' formula, I have Christine Whitmore's formula. A lot of doctors create their own customized formula. So for the rescue installations, we call it a rescue because it will rescue you out of flare. The base is heparin. The anesthetic is usually lidocaine or marcaine. They will often put some Solu-Cortef in it, steroid in it to calm inflammation, and they might even put an antibiotic in it. The protocol for rescue installation, published rescue installations like the Parsons protocol, the protocol was 3 a week for 2 weeks. Now, who can get to their doctor 3 times in a week? That's just impossible right now. But the original protocol was 3 a week for 2 weeks and then once a week for like a month or 2 months, something like that. That's just impossible. I don't know anybody who's able to do that unless you're doing it at home. Now the protocol is kind of like once a week for 8 weeks, reevaluate, see how you do. If you've responded well, you can do another course. But to do it for 20 years makes no sense to me at all. At some point in time, somebody has to ask, is this working or not? So Mary says, I get some periods of relief with an installation for 3 to 4 days. I put it in and can have as many as 4 to 6 hours pain-free, which allows me to cook, shop, or whatever. And that said, I have had infections. And so, Mary, I can understand completely why you would do them. Because to have 4 to 6 hours pain-free so you can function is great. Because there are just a lot of people who just simply do not understand how disabling bladder pain can be, how agonizing it can be. And to be able to have that relief reliably every time you do it, that's a win. But I would also challenge you and say, okay, so we're managing symptoms a bit, but what's the underlying problem here? What's the underlying problem? And can we address that underlying problem also so that you wouldn't need to do bladder installation so much? Nancy said she stopped her bladder instill. She finally figured out it wasn't her bladder. Melinda says that they last for about a month. Mira said, I did DMSO years ago with an older doctor and it did beat me up. Yeah. Melinda says, I've been doing monthly bladder installations for the last couple of years, heparin, steroids, sodium bicarbonate, and an antibiotic. I think this has kept me in remission. Well, how do we define remission? Instead, I'd want to know what the underlying problem is. Because and again, I'm not opposed to it in a way. Like Mary said, it gives her relief. But in the same sense, I think we have to go back and do our due diligence and ask ourselves why our bladder is so vulnerable in the first place. So as an example, I've been working with a patient. Well, she was in our meeting on Friday, actually, because we did a drop-in meeting on Friday night, who is having a hysterectomy because she has a fibroid tumor pushing on her bladder. And hopefully that will help. Let's see what's happening over here on YouTube. Isabel says, I was diagnosed with overactive bladder post-cystoscopy last September. Doctor prescribed Mirbitric, can't tolerate. Symptoms have escalated. Pelvic pain, physio, diagnosed a prolapse of the bowel and bladder. Is physio the best plan? Hell yeah. Absolutely. And so anytime the bladder falls out of position, anytime it's not being held up, then that causes an array of problems. Sometimes the bladder folds in half and gets stuck. Urine gets stuck where it shouldn't be and it can't drain out properly. If you have a uterine prolapse, a vaginal prolapse that's pushing against the bladder, making it hard for you to release urine. I mean, that's a structural abnormality, and they have to work on that structural abnormality. A rescue installation is not going to fix that. We've got to work on the prolapse. And the other thing that we've learned more recently is a lot of prolapses are due to a defect or an injury to the uterosacral ligament. And it turns out the uterosacral ligament also supports very important nerves for the bladder. And if the uterosacral ligament falls out of place, if it stretches out of place, the nerves start to stretch. And when the nerve starts to stretch, you start getting bladder symptoms. Even though the bladder wall's healthy, it's the nerve outside of the bladder that's causing the problem. So we have new research now that's proposing uterosacral ligament laxity, known as posterior fornix syndrome, as a new phenotype for IC. And I completely agree with that. If you have a history of prolapse, then we've got to look at that we've got to look at that uterosacral ligament. As an example, a good friend of mine just had a very, very, very severe IC. I've known her literally for 25 years. We talk all the time. And she, her symptoms started in childhood. She shared with me that she was never able to run at school without leaking urine, and she hid it from everybody. She didn't tell her mom. She didn't tell her teacher. So she just didn't run. She didn't try to work out. I mean, there's clearly a fundamental structural problem. And then fast forward, diagnosed with IC, really severe IC, all these problems, working as a teacher, trying to stay working as hard as she could with high levels of pain. I couldn't admire her more. And then one day, like 5-6 years ago, she just started leaking uncontrollably, like waterfall urine. Couldn't stop it. And when they went in to repair it, they actually found a birth defect. So all this time, she'd had a birth defect, like an extra long perineum or something like that, that was playing a role in her symptoms. Well, anyway, she just had a hysterectomy because she developed a prolapse, really, really severe prolapse. And the first surgery failed, another prolapse. They go in, finally do a hysterectomy, and they found that her uterosacral ligament is stretched out like to 2 or 3 times its size. So I do really believe that this underlying problem with her ligament is probably playing a big role in her symptoms and all the pain she's had. Fascinating. One other thing about bladder installations, that this is to the people who are in the recurring UTI camp, because there are people out there who believe that IC is caused by recurring UTI. You know, I do not believe that. I think only a tiny percentage of patients have a infection. And it's not just bacterial infection, it's fungal infection and viral infection. And we have the research that has found that in IC patients. But Curtis Nickel, in his discussion of the groups of patients with IC, talked about the recurring UTI, and he's now using, or he was using, antibiotic bladder installations to bring the antibiotic directly to the bladder wall. And isn't that freaking brilliant? Oral antibiotics cause such damage throughout to your biome, through your whole body, to your gut. And if you believe that you have recurring UTI, then doing bladder installations with antibiotics makes a lot more sense. I don't know. I'm just going to throw that out there. Anne says, can you get a UTI from vaginal atrophy? You can get you are more prone to UTIs because you are in estrogen atrophy. How does the bladder wall defend itself from infection and from urine? It has a really thick coating of mucus. Let's see, I have a slide. Where is my, hold on a sec. Okay. So let's look at this picture. This is an old Elmeron postcard, but it's very useful. Okay, so here is a three-dimensional or side view of your bladder wall. We have your urothelium. These are your umbrella cells. These are big, giant cells. Biggest cells in the human body are right here. They have what we call very, very tight junctions to keep urine out, and to keep bacteria out. And then on top of that is what we call the gag layer, the glycosaminoglycan layer. The gag layer acts as a barrier. It's hydrophobic. It pushes urine away. Unfortunately, the gag layer is estrogen dependent. So when you're young and have a lot of estrogen, you got a lot of gag. But when you're older, you don't have the estrogen as much, which means you don't have a lot of gag, which means, hello, urine or bacteria can now reach these cells and infect these cells. And that's why if you've had 2 infections in 6 months, 3 infections in a year, your diagnosis is a recurring UTI. And in addition to giving you antibiotics, they almost always make sure you're using a topical estrogen product, because when you give that skin estrogen, it produces gag. I attended a lecture with Dr. Anthony Schaefer years ago at the National Institutes of Health, and he was talking very specifically about recurring UTI. And what he shared is that about 24 hours before they found it in the bladder, it was living in the vagina quite happily, which then made them ask, okay, what's happened to our vaginal defenses? Why has the vagina become a safe haven for bacteria? And the answer goes right back to estrogen atrophy. And so if you're older and getting recurring UTI, it's not just about the antibiotics, it's about improving your skin health. And the way we do that is with estrogen. And of course, one of our challenges here is a lot of women try estrogen and it burns, so they don't want to do it. They don't understand that the burning is actually just a reflection of how dry that skin is, and the burning will go away. You just have to keep using, every time you use the estrogen, your skin plumps up and starts to produce mucus. Probably take 10 days to 2 weeks for the burning to go away, but it will. So again, it's about understanding the physical health of the tissue, understanding the health of the skin, understanding the health of the muscles, understanding the health of the bone, etc. All right. Karen says, I was just diagnosed with IC, had a hysterectomy in June of 2024. I've been suffering since that time. I have pelvic wall muscle problems too. Okay. You're so tired of the pain. I know, honey. Did the pain start before or after your hysterectomy? Why did you have the hysterectomy? Did you have the hysterectomy to try to address the pelvic pain, or did the pelvic pain start after the hysterectomy? That's an important question. I need to be able to have you answer that question before I can answer your question. Diane said, had a cystoscopy on Tuesday, new urogyne injected steroids into the bladder wall. He said I had Hunner's lesions that had been cauterized before and it tore open. Okay, that's a good treatment. That's a good treatment. Injecting a steroid into a lesion will help to reduce some of that inflammation. That's good. But in the same sense, we have to try to understand what causes lesions. And now we know that viral infections such as polyoma BK, Epstein-Barr can cause lesions. And we also know that USL laxity can cause lesions. And so it would be interesting, Diane, to know if you've had mononucleosis. Because if you've had mono Epstein-Barr, then you probably have some residual Epstein-Barr virus living in your bladder causing the lesions. It's possible. And if that's the case, then throwing in an antiviral might be a great approach. And we now have some new research studies focusing on the identification of virus, and then once they find virus, giving patients antivirals. Katie says, can you please give me some more information about urethral pain syndrome? I think I am in this subtype, but the links with the extra info don't work anymore on your website. Oh, they should. Oh, maybe some of the research. Well, no, the research studies should work. Okay, so urethral pain. So let's just be clear here. What is the urethra? You'd be amazed at the number of patients who don't know what the urethra is. So you've got two kidneys. They each have tubes, and those tubes drain into the bladder. Those tubes are called ureters. So now we've got urine collecting in the bladder. How does the urine get out of the bladder? It is through the urethra, a tube. In a woman, it's about the size of your little finger. In a man, it's like 6 to 7 inches long. One of the challenges of the female urethra is because it's so short, it's really easy to push bacteria into it. So this is why some women get bladder infections after sex. Just the act of sex just pushes bacteria up there. But there are a number of potential causes for urethral pain. The first thing that we always look for is estrogen atrophy. The urethra is kind of the canary in the coal mine when it comes to estrogen levels. It's the first part of the urinary tract to start screaming, because just as the bladder has a protective mucosal layer, so does the urethra. And when your estrogen levels drop, or you're on Lupron for endo, or if you're even on birth control, or if you've had a total hysterectomy, you don't have the estrogen anymore, which means your urethral cells cannot produce mucus either, which means it's starting to get dry. So estrogen atrophy in the urethra is very, very common. It happened to me when I was 51, and it felt like a drop of urine in my urethra that would not come out. And you know, guys, listen, my IC self-help skills are excellent, obviously. I threw everything I knew at this new urethral pain. Nothing touched it, and it got worse and worse. And at the end of 3 months, I threw myself on the mercy of my urologist and said, please help me. What is this urethral pain? I've never had this before. He took one look at me and he goes, Jill. And I'm like, what? Oh, what? I mean, imagine I'm laying on the table in the stirrups, looking at him through my legs. And he's looking at me through my legs going, Jill. It's a really funny moment in time. And I'm looking at him going, what? What'd I do? What'd I do? And he said, didn't you use the estrogen cream I prescribed for you last year? And I very meekly went, no. And he said, why? And I said, listen, I'm 25 years old on the inside. I can't possibly have an age-related issue. And then he explained very clearly that the urethra is the canary in the coal mine when it comes to estrogen atrophy. It's the first part to scream. It feels like there's a drop of urine stuck in your urethra that won't come out. And he prescribed topical estrogen for me and had me rub a pea-sized drop into the entrance of my urethra, and 10 days later, it was gone. And if I don't use it, it comes back, even now, because I'm obviously older and even in more estrogen atrophy now. So concept number one with urethral pain is going to be estrogen atrophy. Concept number two with urethral pain is going to be tight pelvic floor muscles. If you are struggling to urinate, if your urine spray is spraying everywhere, like instead of going straight down into the toilet, you're like, it's ricocheting off the walls of the toilet. If it's thin, if it's narrow, you may have tight pelvic floor muscles, and that's squeezing your bladder. Or you could even, if it's sharp urethral pain, especially if it's accompanied by pins and needles, areas of numbness. Oh, I have another really interesting story to share. It could actually be pudendal neuralgia. It could be a muscle squeezing a nerve that supports your urethra. That's very interesting. You could have a infection of the periurethral gland, which is halfway up the female urethra. That's like a deep pimple that won't drain. You could have chemical sensitivity to a laundry detergent, fabric softener, toilet wipes, bathroom wipes. What's that big brand name that's very popular? It starts with a C. Like notorious for irritating the skin down there. Happened to a family member, a guy, as a matter of fact, who had started using it and had a lot of urethral pain. Anything that leaves a scent in your underwear needs to not be used, because that scent is going to gas off and irritate the tissues. If I put on a pair of underwear washed in Cheer or Tide, I don't even know if they make Cheer anymore, but I know they make Tide. For years, I would have urethral burning within 5 minutes. Menstrual pads. You got to look at those menstrual pads, because those super, super thin menstrual pads, the reason they absorb fluid is they have a chemical layer in there that pulls in the urine. The problem is they gas off chemicals, which can irritate the skin. So some women get a menstrual pad shaped rash on their vulva and on their skin from this chemical. Injury, trauma. I've worked with a number of patients who, like people who've been kicked in the crotch to the point that they bled. People who, I remember one lady was jumping over a fire hydrant, landed right on top of the fire hydrant. She was bleeding, had a really bad injury down there. Injuries and traumas too. So how do we fix urethral pain syndrome? Well, if it's tight pelvic floor muscles, you're going to do physical therapy. If it's estrogen atrophy, it's topical estrogen. If it's pudendal neuralgia, we're going to have to silence those nerves, maybe with some topical estrogen. Your doctor can actually order a compounded cream that might include ketamine, baclofen, lidocaine, that would help to calm the nerves down of your skin down there. That's always a possibility too. But urethral pain is definitely challenging. Let me share this twice in the last week. I had the same thing happen, never happened before. I had a gentleman call who every time he flared, his foot went numb. Every time he flared, his foot went numb. And then I was working with another patient, I think on Friday, it was a woman, same thing, her foot went numb. And she would have sciatica-like pain down her leg every time her bladder flared. And I said to both of them, I went, well, number one, your bladder can't do that. Your bladder can't do that. What does that is muscles squeezing nerves. That sciatica-like pain, that pain when sitting down, both of those patients had muscles so tight that they were actually making their feet numb. And it was back to physical. One of them had never even had a pelvic floor assessment. Nancy said, I wish we could order all this from you. Honey, you can just call, sign up for a coaching session. Okay, let's go to, actually, I'm going to come back to Facebook here for a moment, and then I'll come back to YouTube. Like Facebook is calming down like right now. Okay, that's good. It's not jumping all over the place like it normally does. Tiffany said she'd only done one bladder installation, felt great until you peed, didn't work. She scheduled a hydrodistension, told me to give it 2 weeks. I'm on the first week. Currently still flaring since October, can no longer take OTC due to it wreaking havoc on my irritable bowel syndrome. So Tiffany, I'm not against a hydrodistension. I don't like guessing. I like facts. Letting somebody look at your bladder to me is important, especially if you've been in pain for a long period of time. If your bladder comes back healthy like mine did, then we have to look outside the bladder, specifically at the pelvic floor, as potentially the underlying source of your pain. Natasha said installations sound terrifying, so I've never tried one. No, not terrifying at all. Listen, if you're in a lot of bladder pain, letting them put an anesthetic in your bladder to give you a couple of hours without pain is not a bad idea. Like Mary said, she's done that. It's all about understanding its purpose. It's about symptom management. If your symptoms are really out of control and you just need a little bit of relief, a rescue installation, not a bad idea. As Mary says here, they're easy once you get used to doing them. Okay, I'm going to sneeze. Hold on. I'm going to sneeze. Excuse me. Oh, I should have turned my head away from the microphone. Sorry about that. Okay, Renee said, I've had 2 UTIs in the last month. I ordered Microgen and I'm on phosphomycin. I'm hoping this gets rid of it. Well, it'll be interesting to see. I mean, what did the Microgen test find, Renee? Mary says she's been sitting with a heating pad. I've been sitting a lot with heating pads. I use heating pads at night a lot. I use our we have a great microwavable heating pad in the IC Network shop. Perfect shape for the pelvis. Really good really good heating pad. Renee said, I had my prolapse surgery. They used ligaments to tack the bladder up. I'm pretty sure. My urologist just said that on the antibiotic into the bladder. Okay. Sherry said, I just started going to pelvic floor physical therapy, but she wanted me to do leg exercises and Kegels for a few sessions before doing internal work. I was hoping to get started on the internal work, have her assess me for a possible Why? I mean, has she even done an internal exam yet? Why? I mean, the Kegels are for incontinence and weakness. If your muscles are really tight, the last thing we want you to do is Kegels. Our AUA guideline says clearly Kegels are not supposed to be done. So I'm baffled. Why would she do that? Britt said, I took that drug and it finally helped me for like 10 to 15 years. Now I'm suffering and I know stress is my main factor, like in a cat. Absolutely. Yeah, it is. I have a great quote here. You know what? I had it on Post-it and it fell under my desk. We are not designed to heal if our body is in fight or flight. Isn't that great? Our body is not designed to heal if we're in a constant state of fight or flight. That's why managing anxiety is so incredibly important. Mary says, how do you know if you're taking enough estrogen? You look at your skin. The doctor can look at your skin and tell you if you are or not. Renee says, does NAC break up a biofilm? I have bacterial vaginosis right now and yeast. My estrogen set me on fire. Can I mix it with something to stop the burning? You could try lidocaine. Like over-the-counter Anacream, which is designed for rectal pain. You could potentially use that on the not internally, but externally. Talk to your doctor about it. Your doctor might be able to prescribe you a lidocaine jelly that might help. The fact that estrogen set you on fire tells me your skin is extremely compromised and extremely dry, or there's something in that estrogen that was really burning you, like alcohol. This is why we suggest a compounded estrogen cream as compared to a brand name like Premarin. And does NAF break up a biofilm? Okay, so guys, let's biofilms, 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 biofilms. Everybody's been talking about biofilms. Biofilms are bad, right? Well, no. Bacteria have lived in colonies of biofilms for millennia. We have biofilms in the human body that are supposed to be there. But a biofilm is a colony of bacteria, not the same bacteria. It's a lot of different types of bacteria that come together, they merge together, and they do it in a specific order. So specific bacteria on the inside, specific bacteria on the outside. And then working collectively, they secrete a waxy coating to protect the colony. And then when they eat all the food inside that colony, it breaks open, they all swim away, and they all form little colonies elsewhere. The problem with taking a biofilm busting approach, and this goes back to years ago when I was reading up about it, you don't want all the biofilms to burst open at one time because that would overload the human body. And sometimes, don't quote me on the source of this, we could argue that a biofilm is really kind of a healthy way to keep bacteria isolated. And I read that somewhere. Don't ask me where. But there was a very specific concern that if you took something designed to break open biofilms, that you would release all these bacteria at once, even potentially in the circulatory system, even potentially in the brain. And that might create a situation where the human body is now struggling to control it. So I don't think that we have any significant data that has found that a biofilm busting approach in the bladder works. I can see them putting something in a bladder. So let's argue that maybe you've got some biofilms on the surface of your bladder wall, and if they put something in your bladder installation to break them open, combined with an antibiotic to kill them all at once, maybe. But I don't know anybody who's doing that. And I don't know any research that's ever connected a biofilm to IC. Let me just look. Let me look at the National Library of Medicine real quick. My favorite place to be on the internet, because hello, I'm a geek. Okay, so let's just do interstitial cystitis. Let me just see if there are any biofilm studies. One from 1998 from Japan. And one study in 2014 about fosfomycin in a veterinary practice. Okay. So not a single published study linking biofilms to interstitial cystitis. Let me just play devil's advocate here and let me bladder pain. Let me search for bladder pain. Biofilm. Let's just see if that comes up with any more. 7 studies. One's on catheters. That makes no sense. One studying models of infection. One on uterine stents. A patient who had a pacemaker who ended up with endocarditis. and a study in 2009 on biofilm and other causes of pain and catheterization. Okay. So there's just no data, guys. There's no data. You know, the internet has struggled with these embedded infection people from day one. I mean, I was there. and the harsh reality is that we're simply not finding embedded infection in the vast majority of patients, nor are we finding bacterial biofilms. And of course, now that we're phenotyping, now that we know that 80 to 85% of patients have tight pelvic floor muscles, I think we can seriously throw that theory out. And more importantly, now we know that the damage that long-term antibiotics causes in the development of something called lactobacillus inners in the bladder, which is a pathogenic lactobacillus. So anybody out there who's telling you you need to be on long-term antibiotics, they're wrong. We've got research showing that that actually can lead to devastating, far more complicated infections with much more difficult to kill bacteria, like C. diff and like lactobacillus inners. All right, let's come back here to YouTube. Kim said, I had my 6-month blood work and urine test on Wednesday. My primary care provider called and said I have a UTI. I disagree. Everything is normal, but the white blood count was 1+, which is mild. No bacteria, blood, nothing. Everything was negative except leukocytes. Your leukocytes was slightly elevated. Kim, you're right. I mean, listen, it's quite normal for why does urine often have an elevated level of leukocytes? Well, it goes back to this. So let's go back to this for a moment. So let's just say that you have had some coffee and you have estrogen atrophy, and the acids from the coffee have now penetrated and have reached these cells, the urothelial cells in your bladder. Now, these are not passive cells. These are very active cells. And they go, help, 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 I need help. And they trigger help to they request help from the immune system. And the immune system then sends white blood cells to fight the invader, right? Because the assumption, I think the body is hardwired to think it's bacteria, but, because they didn't have coffee a million years ago when bladders were created. All right. So anyway, we have an invader. It's a coffee irritant. Your immune system sends white blood cells to the area. Now, the white blood cells have gotten there through the blood vessels. So now at the capillaries in the bladder wall are swarming with white blood cells. But how does the white blood cell get from here to here? The answer is it opens up. It opens. So the capillaries open up and they release white blood cells and they release red blood cells. And the white cells then swarm the area and kill whatever the invader is, if it's living. And so one of the reasons why you might have elevated white blood cells in your urine is because you're of a bladder wall flare from food. I mean, that could be it too. And that's also one of the reasons why many of us have microscopic blood in our urine. I've always had microscopic blood in my urine. I've never not had microscopic blood. And yet my bladder is perfectly healthy. Now, that's very different from visible blood. If you're peeing and you see blood clots in the toilet, or your toilet is filled with red urine, that is a call your doctor immediately moment. But if they do a urine test and they feel elevated white blood cells or elevated red blood cells, microscopic, usually not something that we're worried about that much. So, Kim, I think that it would be... I think you're taking the right tact. I mean, I can't tell you to ignore your doctor, but I think what you could say is, okay, doc, I hear you. I understand what you're saying. I want to wait a couple of weeks. Let's see if my symptoms get worse. If my symptoms get worse and it feels like something's happening, then I will consider the antibiotics. But right now I'm asymptomatic. Nah, I just don't see any reason to damage my biome and potentially trigger C. diff or something like that. I mean, just do the wait and see. Why not? Diane said, I think I had mono at 17 years old. So what test would I ask my urogyne to do if I have Epstein-Barr virus, to get him to give me an antiviral to get rid of the lesion? They can do a blood test to see if you have active infection. The research, if you email me or call me this week, I will give you the research study. It's actually on our website already. If you can go to the IC Network website and then just search for virus, just put the word virus in the search bar, and it will bring up some of the studies and some of the blogs that I've written. And at the bottom of the blogs is the research, and you can actually click on the research, print out the research, and give it to them. And so that's, I mean, then the really interesting thing here is it was the Europeans who 6-7 years ago, they're the ones who found the virus. They were comparing the urine of patients with lesions and the urine of patients without lesions, and they consistently kept finding virus in patients with lesions. And we're like, well, isn't that interesting? And they produced multiple studies over a 5-year period, which were all supporting and validating the viral theory, while the American research, the National Institutes of Health, was actually saying nothing about it. And we're here. I mean, like, I was in these meetings. I was in the meetings right here going, all right, US, what do you say about the viral theory? Does it have any validity? Well, interestingly, in that 5-year period, they were doing their own viral study, because it turned out the MAP Research Network, which is our National Institutes of Health IC Research Network, and God only knows what's happening to it right now. I pray it's not being dissolved. They had urine samples from patients over time. So they went back and they looked at the urine samples and they found it. In about 5% of IC patients, they found virus. So it was either last year or the year before that we had, I think, our second study that was looking at using antivirals. And so they did PCR testing on urine. And if they found traces of the virus, they then gave them an antiviral, and the antiviral completely suppressed the infection. But it's very, very early. It's very, very early in that research. But I'm not surprised you had mono. Listen, the Epstein-Barr virus, I was watching like a documentary on it early last week. I didn't realize how destructive the Epstein-Barr virus was, and that you getting mononucleosis as a child can lead to lifelong problems from that Epstein-Barr virus. I think I want to do an article on it. I mean, I'm absolutely shocked. I just didn't understand. For example, if you've had active mono, they don't want you moving. I mean, you need to be resting massively for months, for weeks or months, until that infection calms down. Katie said, thank you, Jill. This info is very helpful. You are the best. Here, hold on a second. Okay, good. I'm too young for estrogen atrophy. Girl, don't say that. Don't say that. We have an 18-year-old study of an 18-year-old whose symptoms began suddenly over a period of year. They got worse and worse and worse and worse. It was from birth control. The birth control put her into an early estrogen atrophy. Vesna says, hi, Jill. Philip. Okay, in the UK, Ilaril, is that most used in the UK? I'm not sure, probably. You could reach out to the bladderhealthuk.org and ask them. We just had an international IC meeting this week on Friday. I gave a presentation on phenotypes. And the Bladder Health UK group did a really nice job of sharing their history and how they got started. I actually knew the two founders. We became friends. And they were originally the Interstitial Cystitis Support Group of the UK, and then they became the Cobb Foundation, and now they're Bladder Health UK. And they work with a lot of conditions, not just IC now. Okay, my hair's being weird. Hold on. Vesa said, if he did cauterization of Hunner's ulcers, is there a possibility to make the bladder capacity smaller? Yes. Whenever you do cauterization, you're leaving scar tissue, which is going to reduce the flexibility and the contractibility of the bladder wall. Kim said her urine was clear and yellow. She had C. diff once. Ugh, never again. Exactly. And you also had mono at 17. I got, hold on a sec. Thank you for whoever sent stars. Guys, if you find these meetings helpful, please come on over to the IC Network and sign up to get our free newsletter. I write those newsletters. I don't send out spam. I share all the latest information. And best of all, we have a magazine, the IC Optimist, that you can subscribe to. And that's what keeps these meetings happening. I mean, it's expensive. It's expensive to run an internet group like ours. I mean, the server fees alone are like $5,000 a year. The internet fees for me to stream on 2 platforms, it's $400 a month. And times are tough right now. And so I'm cutting out Comcast. So I'm only going to have one internet. I'm going to try to bring another one in, but I just can't afford that right now. It's the economy is too scary. Like, I'm literally anxious about the future right now. I'm anxious about my Social Security. I was hoping to retire in like 5 years. And I just, as a business owner right now, it's a very, very scary time. So if you can become a member for $25 a year, that would help tremendously. And most importantly, look at our book, IC 101. It's, or if you're trying the supplements, please buy them from us. Don't just go to Amazon. Buy them from us, because that keeps these meetings happening. That keeps me answering the phone and my staff working. So we really appreciate all of our members very, very much. Okay, so YouTube, very, very good. Hey, we got a big crowd on YouTube today. Hi, guys. Nice to see you. So I don't have access to fiber internet. They offered me fiber if I would pay $700 a month for 3 years. Not happening. So I'm only going to have AT&T. And AT&T has not been good at streaming on 2 platforms at one time. I hear that there are some new apps that might help make that happen. I'm going to explore those. But I'm also considering doing 2 separate meetings on Sundays. I'm thinking that maybe I might do a meeting at noon, from noon to 2, like on YouTube, and then from like 2 to 4 on Facebook. I'm thinking about that. I've got till the 21st to figure that out, because that's when the Comcast is going to turn off. Just being perfectly honest here. I'm just like you. I've got all the same worries that you do have. Lori's, let's see. Natasha said, I used to get pain running down my leg during a bad flare. Natasha, that tells me that's a pelvic floor flare. Lori said she's going to do a replay if she has storms coming. Yeah, we are in a big storm right now here. I'm kind of shocked, actually, that everything's going so well. Susan says, what can I do to help with urinary frequency? Urinary frequency is coming from the alpha afferent nerve in the bladder wall. See this green thing right there? You only have two different types of nerves in the bladder wall. You've got an alpha afferent, which controls frequency, urgency, and you have the C fiber, which controls pain. The alpha afferent nerve is the nerve that tells you when you need to pee. It is easy. It is designed to be easy to turn on because you use it all day. The C fiber pain nerve actually is not supposed to be on, and it's actually hard to turn it on, usually. So whenever we've got frequency urgency, what that tells me is that this nerve is being inflamed in some way. It's either being inflamed by something getting through the bladder wall. If you have a Hunner's lesion in the bladder wall, if you have estrogen atrophy in the bladder wall, but it can also be inflamed from tight muscles. Because if you got tight muscles down here squeezing this nerve, that nerve is not going to like it either. So concept number one here, let's just say you have extreme nighttime frequency. You're getting up every 30 minutes. I associate nighttime frequency mostly with food. Those are usually, especially if it's happening every night. If you were on the phone with me, we would be going over in detail what you're eating or drinking. Because in many cases, there's something that you think is healthy that's not healthy that's triggering that. And you can't kid a kidder here. You'd be amazed at the number of patients who tell me, oh, I follow the icy diet, and about 10 minutes later they confess that they have green tea or soda or everything. And also, guys, matcha, no matcha. Green tea, agonizing in the bladder, very acidic, extremely caffeinated, very neurostimulatory. I had a patient last week who had started drinking matcha, and she flared, and she didn't understand that the matcha was green tea. So no matcha. Lisa says, can I talk about the different installation solution? And I'm sorry, you guys, I'm behind on Facebook now. I did, but if you have a question again, go ahead and ask it again. So we're not doing chlorpactin or silver nitrate. Those are bladder strippers. DMSO has fallen out of favor because number one, it hurts. And number two, it has more side effects. And number three, we really don't understand what it does. It's got too many methods of action that are not understood quite yet, which scares me a little bit. Rescue installations are by far the most popular bladder installations that are done now. A combination of heparin and lidocaine or marcaine, solucortef as a steroid, and maybe an antibiotic. Tricia says, do you recommend bladder installation for Hunner's lesion phenotype? Pros and cons. I don't, but doctors do for symptom management. What I have found, but again, I'm not your doctor. I can't give you medical advice. You've got to put my comments into proper context. Your doctor is way more important than I am. What I would say to that, and what the research shows, is that Hunner's lesions respond best to lesion therapy. And that means cauterizing the lesion to stop the bleeding, or known as fulgurating, or injecting a steroid into the lesion. Because lesions, when you biopsy a lesion, it is warfare happening in there. There's massive inflammation in the middle of a lesion, massive. And of course, now we understand why, because if it's a viral infection, that would explain that your body is fighting a virus. And of course, there's inflammation there. So the flaw of thinking that lesions are a treatment for IC is that you're avoiding the things that we know have the potential of really helping. That's kind of getting back to, are you treating the symptoms, or are you focusing on the underlying causation? Now, Curtis Nickel, in his guidelines, in his phenotypes for IC, he encourages bladder installations to help manage the symptoms of Hunner's lesions. I just find that patients get confused. Patients think that a Hunner's lesion is that a bladder installation is going to fix a lesion, and there's no evidence that it does. But if it helps to manage your symptoms, power to you. I'm just very focused on, can we fix the underlying problem? If that underlying problem is from the visceral plexus being inflamed because your ligament is weak, then we can fix that. And if we fix that, that's a cure. But will bladder installations cure a lesion? No. Will an antiviral cure a lesion? Well, if they find virus in you, it will put it into remission. But once you have a virus, you have a virus. Vesna says, Philip has polyoma BK, first in urine and blood, now only in urine, which is a therapy for it. Okay, so the antiviral is a therapy for that. Dr. O proposed him steroid injections for Hunner's ulcer. Is there any side effect? No, the steroid injections actually have gotten very good reviews in research. The risk associated with a steroid injection is just the risk of anesthesia and the risk of having the procedure and the fact that they're going to have to put something up his urethra and then you could get infection from that and stuff like that. But a steroid injection itself, if I remember correctly, and all right, let me credibility test myself here. Let's go to the National Library of Medicine and let's do risk of triamcinolone injection in Hunners. Let's see if anything comes up. Nothing. Okay, so hold on a sec. Let's go to a study. Triamcinolone Hunner's lesion. Let's see. Okay, here's a study from 2020. The clinical efficacy of triamcinolone. Okay, let's see if they found side effects. Submucosal injection of triamcinolone can improve the clinical symptoms and quality of life in both men and women with Hunner's lesion. Patients with advanced age or more severe IC related to symptoms may benefit even more from triamcinolone injection. And hold on, let me just open up it's a free paper. So okay, hold on, let's see. 35 patients in the study from 33 to 80 years of age. Patients had significant improvements in frequency, urgency, and pain, quality of life. Okay, so hold on. Patients with an advanced age, high pain, were more likely to benefit from it. Okay, I'm just looking for adverse events. Anything. All right, hold on. Triamcinolone is a long-acting corticosteroid with anti-inflammatory, anti-itching, and vasoconstricting effects. Has a strong, long-lasting anti-inflammatory and anti-allergenic effect. It is inexpensive, extremely well tolerated when used locally. There you go. Extremely well tolerated when used locally. They're not reporting really, they're not discussing any adverse events that I'm seeing in my quick review of the study. Danielle says, how long does it take for PEA to work for pelvic pain and natural peeing? Been doing D3 for years, magnesium glycinate 1 week, and the magnesium does relax my bladder a lot. Well, interestingly, the IC study used it for like 4 months, and there was a significant reduction in pain over time. We had a brand new PEA study with menstrual cramps that showed that patients with menstrual cramps could experience a pain reducing effect of up to 25% within 2 hours, or at 2 hours, some got an extra dose and they experienced a pain reducing effect with the extra dose. If you go to the front page of the IC Network, I have a blog on that right now. Okay. Sandy said, I have a stomach virus, nausea, colon spasm off and on, or it's IBS, colon spasms, nausea. What do you think, Dr. Tomorrow? Can you get urge to pee from colon spasms and nausea? Sandy, you can. One of the things that so let's just say you have food poisoning. And with food poisoning, you get out of control diarrhea. And your pelvic floor muscles are spasming like a beast with the diarrhea. And what happens is they tend to get tighter and tighter and tighter. And that can then affect your bladder and make it hard for you to pee. But you need to talk with your doctor and get a proper workup, depending upon how long this has been going on. There's always a chance you might have picked up Giardia from contaminated water. You know, guys, it's just been a brutal year. I mean, we say this every year, but honestly, this winter has been a beast. I feel like all the colds, all the flus are much more intense this year than years past, and I don't quite understand it. But there have been a lot of stomach stuff going around. So good luck, Sandy. Wendy says, my IC pain is really bad. My doctor was saying we should taper off of oxycodone. She said a lot of people said they have no pain now that they were off of oxycodone. I have been on it for 8 or 9 years. This is the only thing that helped. What are your thoughts? She said that she's the only doctor script for pain meds. What is going on that doctor is afraid to give them to you? Wendy. I hope you're still here. Girl, it's the opiate crisis. And so, gosh, I've written on this extensively because I chaired our California Pain Conference several years ago where we talked about this. And that was part of our governor signing what we call the Pain Patients Bill of Rights. So basically what happened is drug companies. Drug companies saw profit in pain meds. And once they started creating synthetic pain meds, like oxycodone, fentanyl is a synthetic pain med, they saw an opportunity for great profit. And what they did was actually led to criminal charges. One company has been shut down. People have gone to jail. They started telling doctors, and this was maybe 20 years ago, right before the opiate crisis started. They said, hey, we've made this new pain med and there's no risk of addiction. And they were at major medical conferences and telling all the doctors, perfectly safe. Well, yeah. No, they knew it wasn't safe. That actually these synthetic opioids were stunningly addictive. So what happened is the drug companies saw dollar signs. The reselling company, the distribution companies saw dollar signs. And local pharmacies, especially unscrupulous pharmacies, saw dollar signs. And so all of a sudden, the production of these meds skyrocketed. I think there was one pharmacy like in West Virginia in a town of like 900 people that got like, I don't remember the exact amount, but like 250,000 doses of pain meds that couldn't possibly have been appropriate for that small town. And obviously they then went on the black market, and before you know it, people were taking them and getting addicted, and then people started dying. A massive number of people died from overdoses. So then, it became a public health crisis. I mean, we see it today. We just had two young people in my city out of 4 die when they were buying cocaine and they got fentanyl and it killed them. And the problem also is these synthetic opioids are getting stronger and stronger and stronger. I mean, they're not lying. They're imagine giving an elephant tranquilizer, a 1,000-pound animal, to a 150-pound man or woman. Of course they're going to overdose. Of course it's going to be too strong. So the legal authorities got involved and started charging everybody. I mean, appropriately. They went after the unscrupulous doctors who were setting up pain shops. I mean, there are a lot of documentaries on TV about this. They eventually sued the pharmaceutical companies, got the pharmaceutical companies shut down. They've sued the managers. They got access to all the internal documents, and it's just criminal. Eventually, what happened is that the Center for Disease Control was tasked to create new guidelines, medical guidelines. And it was all done behind closed doors. Nobody knew who was on it. And those guidelines came out and basically said nobody should use it. And all of a sudden, when those guidelines came out, people had been using opioids successfully in small amounts over time for legitimate medical conditions got shut down. And some of them turned to heroin instead because living in pain is awful. We then came to find out that the guideline committee, when that was finally released, did not have a single chronic pain expert on it. That guideline committee was actually people in the drug rehab industry, the people who would benefit directly from cutting people off of their opioids, get them into a drug treatment center. Whoa, man, that's bucks. So then the Center for Disease Control reissued the guidelines saying, no, you shouldn't cut these people off, but the damage was done. The damage was done. Doctors are now afraid to prescribe opioid medicine. They are. One of our most brilliant doctors here in California, Forrest Tennant, who spoke at our pain conference, fabulous doctor. They went after him. They've gone after a lot of doctors for prescribing opiates, even if the doctors are prescribing them correctly based upon these flawed guidelines. And the chronic pain experts were infuriated by the fact that this guidelines committee didn't have a single pain expert on it. So what are you going to do? Well, I mean, this is why doing PEA so concept number 1 here is let's not just assume that you have an incurable bladder disease that's giving you this pain. I mean, we're past that. So the first thing that has to happen is you need to be phenotyped correctly to see if we can identify the cause of the pain. If you have Hunner's lesions, we need to treat the lesion. If you've got estrogen atrophy, we need to treat the atrophy. Most importantly, if you have tight pelvic floor muscles, we know that pelvic floor physical therapy helps 70 to 80% of the patients who do it. Okay, so concept number 1 is let's reevaluate the diagnosis. That's what our guidelines say. The patient is not responding to therapy. If they're getting worse rather than better, take a step back, revisit the diagnosis. What did we miss? What could have we missed? The next step is going to be trying some of the over-the-counter things, which are really revolutionary now. And so PEA, palmitoyl ethanolamide, these are the 2 products right here, Peora and P-Leaf. In 2019, we had an IC study with PEA that showed a significant and progressive reduction in pain, Simple over-the-counter supplement, no side effects in the IC study, acts by calming nerves down. It's what I take. That's worthwhile. Would it be good to be off of the opiates? Hell yeah, definitely. You wouldn't have to deal with the constipation and all that other stuff that goes on with opiates. And so your challenge, Wendy, just to be perfectly honest with you, is that many patients see opiates as their only treatment. And they're scared to think that they would never have it again. And my answer back is, you're doing really good covering up the pain, but we still haven't figured out what's causing the pain. And when we figure out what's causing the pain, maybe you won't need the pain meds. Maybe not. And wouldn't that be fabulous? I shared the story last week, a patient that we worked with who came to one of these meetings. She'd been bedbound with pain for a decade. Bedbound. We go through the phenotypes with her. With the group. She's just listening. I didn't even know she was in the meeting. Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia. And I explained pudendal neuralgia, pain when you sit down that gets better when you stand up, pain that occurs when you're moving your body, sciatica, pins and needles, areas of numbness, PGAD, persistent genital arousal disorder, which is a muscle squeezing the pudendal nerve. And she thought, oh, I've never heard of that before, and that I have that. So she does her own research, goes to her urologist, says, hey, doc, I think I have pudendal neuralgia, and this is why. And the doctor looks at it and goes, yeah, you do. I agree. You absolutely do. Then they did some imaging, and what they found was that she had badly broken her tailbone. So her tailbone, let me get my model. So again, imagine a patient in bed for a decade, 10 years. Couldn't work, couldn't do anything. All right. So here is the back of your pelvis. Here is your sacrum. Here are your hip bones, your vertebrae. Hello, tailbone. I want you to notice the tailbone goes down and under, like a cat or a dog that's relaxed. It hangs down and it goes between the legs. Okay? The other thing I want you to notice about the tailbone is look at everything that attaches to the tailbone. The tailbone is literally the functional center of your pelvis. You got muscles that go from one side and muscles that go from the other side. Okay? So what was her tailbone? Instead of curving under, it was curved out. And instead of being centered, it was skewed to one side. Of course she had pain sitting. Of course she had agonizing pain. Terrible tailbone injury. And it turns out a lot of us have tailbone injuries, and my symptoms started after I broke my tailbone. Very, very happy ending. Extremely happy ending. She started working with a physical therapist, and she also worked with a chiropractor. It took a year. They got her tailbone back into its correct position. And she told me she's 95% better. She is no longer bedbound. She is now able to work. And you know what? She was able to get pregnant and have a baby. 10 years believing that she had an incurable bladder disease. And she didn't. She had a tailbone injury. And again, now that we know to ask about tailbone injuries, you'd be amazed at the number of IC patients who have tailbone injuries. A lot of us do. And you know what was funny is it was this book. This was the book when this came out. What year did this come out? Like 5 years ago? Love this book. This is my favorite book by far. You can see it dog-eared. I use it so often. All right, what year did this come out? 2019. Okay. Breaking through chronic pelvic pain. This is for anybody with any history of injuries, muscle, or nerve problems. Great section on pudendal neuralgia in this book. He's the one, as I was reading it, that started talking about tailbone injuries. And I'm like thinking back over my history. Yeah, man, I broke the tip of my tailbone completely off. I used to move it around with my finger. It was disgusting. Disgusting. I could do that for months. And it's still out of position. I mean, the tip is still, it's like a hard knob now where it should be, which is crazy for me. Anyway, so what was funny was it's like, oh, it makes total sense, the whole tailbone injury thing. And then I'm at a national IC meeting with the top docs, and we're in Zoom. And I hold the book up and I go, guys, this is a phenomenal book by Dr. Weiss. And then I brought up the tailbone thing. It said, why didn't anybody ever tell us to ask about tailbone? And one of the doctors goes, Jill, we've been talking about tailbone injuries for the last 50 years. And I'm like, well, you never talked to us about it. Not a single patient has been asked about tailbone injuries. You're talking about it, but what about the patient? Or the patients don't know to tell you that they have a tailbone injury. That's why one of the questions we always ask patients, if I'm working with you, is there an event that you associate with your onset of your symptoms? And we probe about injuries and falls and traumas and things like that. Francis says, wonderful information. Glad to help. Diane said, okay, here, hold on a sec. You guys are busy on YouTube. So how long does it take for PA to work? So the IC study was 4 to 6 months. I felt it probably within 3 weeks. I started feeling much better. My skin really calmed down. All my nerve tingling calmed down dramatically. Diane says, if you have Hunner's lesion caused by active virus and you treat it and the lesions heal, can the virus reactivate and cause lesions again? We don't know enough right now. With herpes, it can. Herpes will activate under periods of very, very intense stress. And that's why getting something on board like lysine daily, which would help restrict the growth of a viral infection, would make total sense. It might be that last piece of your puzzle, maybe. Danielle said, they tell people on Google to take NSAIDs, and that's a joke. I'm on methadone, 70 milligrams. I may get 4 to 5 hours a piece, but I know the addiction issues are very real, but I'm looking up right. It's bad when people are looking in Switzerland to escape the pain and dying with dignity. Yeah. Anne says, I had coccidynia for 1 year. It's gone. Yeah, it might be gone, but the legacy of that with respect to nerve sensitivity and muscle weakness might still be there. I mean, that's a pretty big injury. I was working with a gentleman this week who, lovely, lovely guy, just salt of the earth, young man in his 30s. And he had become addicted to opioids because of his pain, his IC pain, his pelvic pain. And finally recognized that it had become a problem and it was off of opioids. What he couldn't shake was feeling shame, feeling ashamed that he had to use pain meds. And I felt horrified that he was being judged very harshly by family members and friends, despite the fact that he lived and continues to live with very high levels of pain. He's the one whose foot goes numb when he flares. He didn't know anything about the pelvic floor. And his symptoms were very, very consistent with pelvic floor dysfunction, like long-term constipation. And if I remember correctly, he had, he had a bad pelvic injury when he was younger, and he was also a baseball player, big time college baseball player. And think about baseball. How many times do you slide into home base? All that weight. Baseball players are big boys. These are big muscular boys. So imagine 250 pounds or 220 pounds landing on your pelvic floor every single time you slide into home base. It's like, oh yeah, that's a good source of injury. And I really did everything I could to try to take that shame away. That would have been me. I mean, I had no pain care for a year. And when I finally got pain care, it was at an emergency room up in Lake Tahoe. And they gave me a shot and it turned my pain off. And I kind of looked at them like, what? You can turn this off? And I'm a pharmacologist, but my symptoms were so bladder centric, it never even dawned on me to use pain meds, honestly. Get home, I'm at the emergency room for the next 2 days, agonizing pain. They finally gave me a prescription for Vicodin. And the difference between him and me is I have a degree in pharmacology. So I took one Vicodin and it made me nauseous and dizzy. Turned the pain off, but it made me nauseous and dizzy. So it's like, okay. I took a half a dose because you could cut these in half. They had scores down the middle. Half dose turned the pain down. There wasn't any nausea. And then I took a quarter dose. I took a quarter of a pill. And you know what? Quarter of a pill turned it all off, no side effects. And so that was my standing rule when I was in pain. I would take a quarter of a pill. Nobody could ever accuse me of being a drug addict. Taking a quarter of a pill of Norco or Vicodin once every 2 weeks. He didn't have that training. And so he took one, and then when it didn't work, he took two. And when it didn't work, he increased. And of course, that created an addiction dependence. And he goes, oh, if I'd known that, I would have done that. And I went, I know, honey, I know. It's not your fault. You were in agony then, and you're still in agony. So we've got to figure this out. And that's where, again, the PEA, we've got great research with the PEA combined with getting those muscles properly assessed. Because I can guarantee you he had pelvic floor dysfunction. Guarantee it. His symptoms were classic pelvic floor. Oh, and he had a normal bladder on cysto. Nothing wrong with his bladder on a hydrodistension cysto. Okay, hold on a sec. I got to scroll back here. Okay, now Facebook is doing its dance again. Now it's not letting me scroll easily. Darn it. If you asked a question on Facebook and I missed it, please ask again. Renee says, how can I get back into my hormone cream after yeast and vaginal infection? I tried it and set me on fire. Can I slowly introduce after yeast is controlled? Makes sense. Talk to your doctor about that. And by the way, are you talking about surgery on fixing the ligaments? Yes. Hi, Kayleen. She says, instills help with the internal burning bladder pain. I have another one on the 14th and a consult for Botox. I also haven't been going to PT as much because she's so booked. Yeah, that's one of the big problems we have right now. It's getting consistent physical therapy is getting really hard. But Kayleen, you're doing the whole managing the symptoms and it's not getting you where you need to be because we have to focus on underlying causation, and that's muscle, girl. And so the priority here is working on those muscles as much as you can. Sandy's had 4 days of colon spasms and nausea. Yikes. Sandy says, does a tight pelvic floor cause pushing to pee? Yes, it does. Mary says, I'm permitted to take 2 tramadol per day. I find I don't need them twice a day, so I'm pleased about that. 1 per day is fine. I'm having pain every day, especially in the morning into the afternoon, but it usually taper off. Good. Mary says, I have IBS diarrhea. Most of the time I take psyllium twice a day. Helps prevent the diarrhea. Yeah, guys, understand that if you have diarrhea, one of the most important things for you to do is to do a soluble fiber, like acacia fiber or psyllium, which is half soluble and half insoluble fiber. The whole point here is that your bowel doesn't have any fiber. You're basically liquid. And one of the ways we restore that is by giving your bowel more fiber. And it's kind of counterintuitive in a way. You're kind of like, I don't want to do a fiber like that because I don't want to poop. But you're not understanding the mechanics of the diarrhea. We've got to get some fiber in there to soak up the fluid and to give your bowel a little bit of structure. Mary says, I get pain when up on my feet and the sensation of very heavy tummy and legs. Don't know what that's from. Anytime we have persistent heaviness in the pelvis, we want to look at blood supply and pelvic congestion syndrome. If you feel like you're carrying a bowling ball around by the end of the day, then that's a sign you could have a varicose vein in your pelvis, which can collect a lot of blood and give you that heaviness. Lisa says, does medical marijuana help with the pain? Yes, it does. For some patients, it really does. We have a longstanding research study in the IC Network forum about that. I will tell you that patients prefer edibles over smoking, and obviously high in CBD, low in THC. If you're going to go the medical marijuana route, I always encourage you to look at the safety records of every batch that you buy. They need to be testing for pesticides. Make sure it's not contaminated with pesticides. If the company's not doing testing, I would not buy that product from them. Trisha says, does pudendal neuralgia cause knife-like pain when you sit? I have a tailbone fracture, grade 3, I think. Yes. It's more of a zinging electrical pain, like you're being shocked, kind of, sort of. It's hard, it's hard to understand what knife-like pain would feel like. When I used to have bladder wall flares, back when my pelvic floor muscles were out of control and I was in total ischemia, it felt like my bladder was being sliced open by a razor blade. Wendy said, so many people are in pain now. What are they giving instead of oxycodone for the pain? I did lots of things those years, no tailbone injury. Well, they're starting with PEA, palmitoyl ethanolamide. They might go to Neurontin to calm nerves down, physical therapy to relax muscles, muscle relaxants if you have tight pelvic floor muscles that are causing the pain, vaginal Valium suppositories to try to relax those muscles. And yes, opioids if necessary. The American Urology Association guidelines for IC are very compassionate about pain care. They want pain assessed at every appointment, but they want you to do a multimodal approach. You can't just depend on pain meds. We have to do all the other things to focus on the cause of pain. One of the most, Diane, yes, on our websites, right on our website, right on the front page. One of the most tragic stories of a patient, and I need to do a thing on it. I had a husband call me, and his wife was in bed, not functioning in any way with the family. She was just taking pain meds and drinking soda and coffee. That's all she was doing. And she'd been doing this for an extended period of time. And he was exasperated. They have young children. She wasn't helping at all. She was just basically floating and high in her bedroom. So he called me, very, very upset. What do I do? My wife simply will not try anything. All she wants is her pain meds. And I said, put her on the phone. Let me talk to her. So he hands her the phone. It's like, hi, I'm Jill from the IC Network. She goes, hi. And I said, so I hear you're having a big problem with pain. She goes, yeah. And I said, so today we now know a lot of the things that cause that pain. Number one, if you've got Hunner's lesions, your diet can really trigger a lot of pain, yada, yada, yada. Kind of go through it. I mean, I got like 3 minutes with her on the phone. I mean, she was just completely unresponsive. And she just flat out said, I don't care. I'm not going to do anything. All I want is my pain meds and my Coke. That's all she wanted. I refuse. I'm not going to the doctor. I'm not trying anything. All I need is my pain meds and my Coke. And it was the only time I yelled at a patient. And I didn't really yell. I just said, I don't even remember exactly what I said to her. I said something like, you know, your family needs you right now. Your kids need you. Your husband needs you. And you're addicted to pain meds. You are very addicted to pain meds right now. This is not normal. You're using pain meds to escape life. The correct use of pain meds is to help you function. You're choosing not to function at all. And I said, you need help because your family deserves better than this. And the husband, you know, got back on the phone, and I just said, I mean, you know there's a problem. He goes, yes, I know there's a problem. That's why I called you. And I said, you need to call her doctor, and she's probably going to need to be inpatient in a drug rehab. Call your doctor. He called me back like a month later, and she had refused to do anything. Just massively addicted. Heartbreaking. Absolutely heartbreaking. I mean, and so listen, it's really hard to advocate for yourself when you feel like shit. It's really hard to advocate for yourself when you're in agony. I get it. I've been there. I was there. I had a doctor say to me, you will always live with severe pain. This is your life. Get used to it. You will always be a burden on your family. He said that to me in the emergency room at Kaiser Permanente in Santa Rosa. He said that to me. And you know what happened when he said that to me? I went, oh, hell no. How dare you say that to me? I will prove you wrong, you son of a bitch. I will not be a burden to my family. And I came home from that appointment and I started studying. I read everything I could on IC. Before that appointment, I was a victim. I was just in my bedroom crying. After that appointment, are you kidding? I was a fighter. I'm not going to do this. I'm not going to be a burden on my family. And man, it lit a fire in me that burns brightly today, 30 years later. You know, and so it's really, really important that you pick yourself up and start taking action, even little steps. Modifying your diet. Ask action satisfaction. To get satisfaction, you got to take action. To take action, you got to ask a freaking question. So you call your doctor and say, what can I do next? You call the physical therapist and say, what can I do? Oh, I love it. The happy pelvis is in here. Hey. She said, what a great point. I had a tailbone injury from a fall down tobogganing a hill at 8 years old, and I believe that was my onset. Yeah, exactly. Think about all those patients who've been told they have an incurable disease when it's actually an old injury to the pelvis. And again, the pelvis is so incredibly complex that, you know, as Dr. Weiss in this book, he said, Western medicine fails the typical pelvic pain patient because doctors play in their sandbox. They don't look outside their sandbox. So a urologist focuses on the urinary tract. A gynecologist focuses on the reproductive tract. Gastroenterologist focuses on the bowel. They don't look at relationships. And as he says in this book so well, nothing operates in isolation in the pelvis. Everything influences everything. The nerves are shared. The nerves for the bladder and the bowel and the vulva and the clit are shared up at the spinal cord. If those nerves are messed up, guess what happens? They can all get inflamed. They can all have issues. And if those pelvic floor muscles are tight and squeezing blood supply, that's going to affect everything down there. And if those tight pelvic floor muscles are squeezing nerves, that's going to create neuroinflammation everywhere. And then your feet might go numb. You might have sciatica going down your leg. And so Dr. Eckenberg, who just retired, but he is working with patients by phone. And I would encourage you, if you are a very complex pelvic pain patient, take it up on that. Listen, he's 85 years old, but he is all there. He is brilliant, and he just released a new book. He's an outstanding second opinion. And sometimes it's like peeling an onion. We start at one layer, we address that layer, and then that reveals another layer. And it's like, okay, now we got to figure that out. And then that releases another layer. And so getting back to the pelvic injury, think about it. We have a broken tailbone. We have damaged muscles, damaged nerves. You have no idea the muscles and nerves. Then one day you're a kid, you can't sit through class. You have to pee all the time. You go to the urologist. Urologist goes, oh, must be an infection, gives you antibiotics for years. Eventually you get the bladder meds. Eventually you're told, hey, you've got interstitial cystitis. The thing is you do all the IC therapies, but they don't work. You're still in pain. Why? Some of you have been on Elmeron for 20, 25 years. Some of you sadly have gone blind. Bladder therapies will not fix tight pelvic floor muscles. And now we know the estimate is 85% of IC patients have tight pelvic floor muscles. And so you know what? Drug companies got rich off of IC patients for years. They did. Selling treatments that didn't have a bat chance in hell of making you better. But now we understand that. Now we have a global acceptance of phenotypes. Now we understand that there are distinct patient groups. Hunner's lesions, bladder wall-driven estrogen atrophy, bladder wall-driven chemocystitis, bladder wall-driven chronic UTI, small group. Our biggest group is chronic pelvic floor dysfunction. And then, of course, the most complex group of all is the widespread pain group, the multiple pain conditions, IC, IBS, vulvodynia, TMJ, fibro, migraines, etc. If you've got two or more of those, you're in the chronic overlapping pain group. And that group is all about the central nervous system and trauma, physical trauma or abuse. I'm in this group too. Why do all the nerves in the body become more sensitive? Because of injury or trauma. Nobody's saying this is mental illness. We call it a central nervous system maladaptation. It's really about how does a child's body respond to trauma? How does that child's brain process trauma? And how does that kind of get hard-coded in our central nervous system? So anyway, Donna says, I saw a new PT this week for pelvic floor muscles. She gave me 2 exercises. Both are done by tightening muscles internally. Do you relax tight muscles by tightening them? No. It's about, okay, so a Kegel exercise, you tighten and then release. You tighten, hold it for a second or two, and then release. The goal of that is to tighten tight pelvic floor muscles to restore muscle tone so you're not leaking. But the problem is if your muscles are already too tight, tightening them makes no sense. It will just make them tighter. So what they will do instead often is suggest something called a quick flick, where you tighten quickly, you tighten just for a spare moment, and then you focus on the relaxation. And often when you have your pelvic floor assessment and they have their finger in your vagina and your rectum, they will ask you to do 3 or 4 Kegel exercises because they're feeling the strength of the muscles. And what's so interesting for me is that when I did that, I could do 2 or 3 Kegels easily, but by the 4th Kegel, I couldn't relax. It was getting harder and harder to relax those muscles. And that's how I was diagnosed with weak muscles and the underlying foundational weak muscles from that old tailbone injury. And then my levator ani were very tight, compensating for the weak muscles. And so therapeutically, first thing we've got to do is relax the tight muscles. Once we have the muscles with normal muscle tone, then we work on strengthening the muscles that are weak. That's the general approach. And happy pelvis, if you're still in here, please feel free to say whatever you'd like to say. I have tremendous respect for you and your work. Mary Jones said, I likened it to a bowling ball in my rectum on my belly. Yikes. Anytime you feel like you're carrying a bowling ball around in your pelvis, that's usually pelvic congestion syndrome. That is the symptom of pelvic congestion syndrome. IC does not cause that bowling ball sensation. Natasha said, my IC started with recurrent UTIs that thankfully stopped a long time ago, but a decade later, I still have pain and urgency. What should I do? So Natasha, you could, okay. The bladder only knows one language: frequency, urgency, pressure, pain. So the only way that the bladder can tell you that there's a problem is by giving you the symptom of a UTI. A bullet wound would feel like a UTI. A stab wound would feel like a UTI. Everything feels like a UTI because that's the only language that the bladder can communicate with. So what I find here, and again, I've talked to thousands of patients over the years who said they had recurrent UTIs, and then I explain that to them, and then I say, okay, did they identify bacteria? And they'll say, oh, probably. And I'm like, no. Did they tell you what the infection was? Was it E. coli, staph, strep, etc.? And when you kind of push to that degree, they're like, no, never. So how do you know you actually had an infection? Did the doctor tell you you had an infection? Or are you assuming you had an infection? And most of them say that because they don't understand the language. And so when we have a patient who's like, oh, I had a lot of infections over and over and over, it's like, okay, when was the last time you tested positive? What was it? Do you remember what it was? And I think it's really important for everybody because we all think we've had infections. I can't tell you the number of urine cultures I've had that have come back negative. Dozens. Because I thought I had infection too. Always track it over time and write it down. Don't just accept a doctor saying I have an infection. Get the species. Is it E. coli, staph, strep? Do a medical record. We have a free medical records kit on our website. Perfect way of tracking this data. This is important data. Okay, so concept number one here is, were those flares? Were they not infections? Were they flares? And if they were flares, then we do the phenotyping. Because I will tell you, every flare that I had that I thought was my bladder was actually a pelvic floor flare. And the way I figured it out, I can tell you exactly the moment I figured it out, is so before all this happened, I actually played tennis professionally a little bit. I was good. I was good, but I wasn't excellent, but it was okay. And I had stopped playing to work. And one weekend, I just had a desire to go hit a tennis ball. And so I went to a local high school and started hitting a tennis ball against a wall. And there were a couple of guys playing, and they said, hey, you want to play? And I'm like, sure. And as a female athlete, I'm very, very used to guys trying to show off because honestly, I was way better than they were. And he hit it as hard as he could at my face. And I got my racket up there and I deflected it, but I got startled badly and I felt myself leak. And I thought, oh my God, there's got to be a puddle underneath me right now. And I looked down and thankfully there was not a puddle, but I could feel a little leak. And I spent the next 3 hours tightening my pelvic floor so I wouldn't leak. I had the worst IC flare that night. I hadn't eaten anything bad. It was a pelvic flare. And that was when I proved to myself all those flares that I thought were infection were muscle driven. So the next step for now is just a proper phenotyping. We need to know what group you're in. You have symptoms, you have pain, you have urgency. If we do a proper phenotyping, we can figure out the underlying cause for that. And if you're welcome to give me a phone call, I would love to. I mean, I do this over the phone with patients all the time. And you know, my job is to open new doors, send you back to your doctor with a new set of questions. But you know, I'm happy to do it. And we're going to probe the first two questions I ask every patient is, how old are you? How old were you when your symptoms began? And is there any event that you associate with the onset of your symptoms? And just based upon those three questions, it's actually really easy to find the possible phenotypes. Lisa said, I'm struggling to keep you on Facebook. I'm sorry, guys. I'm way behind. Obviously, I can talk forever. Renee said, I can't imagine you yelling, but you did good. Yeah, I've only yelled 2 or 3 times in 30 years at patients. Trisha says, how do you get one-on-one conference call with me and become a member? Go over to the IC Network website. Our phone number is at the top of the page. You can just call the 800 number. I answer the phone. I have Heather answers our store phone line. I answer our patient education line. I work one-on-one, first come, first serve. And patients who sign up for coaching always get first priority, but you're welcome to call for free. It's not a problem at all. If you got a couple of questions, more than happy to answer your questions. Absolutely no charge. This meeting is free. The IC Network has always been free. But if you want a longer conversation, like 30 minutes or an hour, then I would ask for you to sign up for a coaching. It's $50 for 30 minutes, and it's $100 for an hour. But I never turn anybody away. If you can't afford it, that's fine. I will talk to you anyway. I try to end those conversations with, if you found this conversation helpful, please think about making a donation to the IC Network or becoming a member, because that's what keeps our phone open. Sue said, good to see you in a little rough couple of weeks. No, honey. Oh, Sue. You know what this is? This is the hug. Oh, it makes me want to cry. Sue has been a long-standing member of the IC Network, and her mom died on the 17th. It's been a rough journey, my friend. I'm so sorry. And you ended up with COVID afterwards, just like I did when my parents died. Oh, honey. If I had known, I would have sent flowers. You know, I adore you, Sue. I just adore you. You have been a wonderful, wonderful member of the IC Network and friend. And you have worked so hard to help your parents, to help them through COVID and all that sort of stuff. And then for your mom to get cancer. Girl. Big hug to you. Big, 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 giant hug. Whew. You know, when you've lost a parent, like I'm a different person now than I was 2 years ago. It was 2 years ago in May that I lost my mom and my dad. And the tears are fine. The tears are fine. They're normal, healthy expressions of love. All right. Kayleen said, physical therapy had me do elliptical and balance board, which was amazing. Now I am all sorts of messed up with my sciatica. Girl, you just got to work on the muscles, hun. Whew. Trisha said, I had to go to a compounded estrogen cream that does not burn me. Yep, that's what I do. Renee said, I still had mine compounded and it burns. I wonder if I can mix it with coconut oil or aloe gel. You could try it. And a good compounding pharmacy might actually put it in aloe for you. Lisa said, who would diagnose pelvic congestion syndrome? That would be a interventional radiologist, an interventional radiologist. Danielle said, I was put on antibiotics before my hysterectomy and uterine prolapse, and the doctor said, do you want Elmeron? I looked it up and said, no way. That was 6 years ago. Now I look back and they mentioned pelvic floor, but nothing else. Okay. But if you're pelvic floor driven, that's the right advice, pelvic floor physical therapy. If you have Hunner's lesions, they would have done other stuff. But I never took Elmeron. Elmeron never really made sense to me because if you swallowed a Band-Aid, would you expect it to come out the other end a Band-Aid? And the answer, of course, is no, we have digestion. We have digestion. And what the bioavailability studies with Elmeron showed was that like 92% of it was destroyed by digestion. So you'd have to take a lot of it over time for it to build up a coating. And of course, the more you take of it, the greater the risk of other side effects like inflammatory bowel disease or, in fact, blindness, retinal damage. Lillian said, the only way I was able to relieve tight muscles in my pelvic floor was manual massage. I had that done as I cried. It was so painful, but once it released, it was okay. Girl, excellent. Excellent. See, you can see, Lillian, where patients get stuck. Because, here you have all this pain and you think it's your bladder, but it's actually your tight muscles. And you do bladder therapies for years and you never get better. Why? Because bladder therapies don't fix muscles. And you just proved with your post that when they relieved your tight muscles, you were okay for a few days. So what that tells me, and the question that we always ask the physical therapist is, are my muscles responding to therapy or am I always locking back down into tension? If I'm always locking back down into tension, then we got to start looking at bones. Do we have a bad hip? Do we have a bad SI joint? Do we have a bad tailbone? Do we have a bad knee? Or for most patients, how is your foot hitting the ground? If you have an ankle that rolls in, rolls out, if you have issues. Oh God, here's another great story. You want to hear another great story? This is another great story from this week. So interesting. And I asked him if I could share his story, and he said yes. Okay, so this was a patient, a guy who called, long-term IC symptoms, and he was the one whose foot went numb. Okay, so anyway, the bladder therapies weren't work and yada, yada, yada. And we start talking about the pelvic floor, and he's got chronic constipation, and he had, anyway, there was really clear that he had pelvic floor issues. I think he had actually even gone to pelvic floor physical therapy briefly, but it, quote, didn't work. So, and again, the question we ask a physical therapist is, are my muscles responding or are they always locking back down into tension? Well, his were very, very tight. And so the question is why? And so it's like, okay, so do you have any issues with your tailbone? Any falls? All that sort of stuff. And do we go through that? And then we go through the knee and then we go to the feet. And I said, so how are you walking? Are you walking normally? And he goes, well, no, I have one foot that hurts almost all the time. And I'm like, okay, like what's that all about? He goes, I have a plantar wart. I've had a plantar wart for 20 years on one foot. And it's like, okay, does it hurt? He's like, yeah. He goes, so what happens when you hurt? Do you limp? Yeah, I do limp. Okay. So what's that going to do to your pelvic floor? You're putting all your weight on one leg. You're favoring another leg. Do you think that's going to affect your pelvic floor? And he was like, oh, good point. Good point. He'd been limping for 20 years. He'd been trying all the over-the-counter plantar wart stuff. He'd never seen a doctor for it. And worse, he didn't know it was a virus, and he was like letting people touch it. Plantar warts are the HPV virus, the human papilloma virus. He was shocked when I told him that. And so in his case, I think that there's a very strong chance that the reason why his muscles are very, very tight is because he's been limping for 20 years. And, he said some days he can walk normally, but when we were talking, it was hurting him. It's like, dude, you got to get that checked out, because that might be why your muscles are so tight and so dysfunctional. Oh, it's fascinating. So could a plantar wart lead to pelvic floor dysfunction? Yes, I think it could, if it's untreated. Okay, Natasha says, my cultures always showed mixed bacterial growth, post-coital UTIs. Yeah, but that's not, here's the thing, Natasha, urine is not sterile. There's always bacteria, good bacteria in our urine. And depending upon your age and where you are with respect to estrogen, if you're, over the age of 45, you're going to have a lot more mixed bacteria because the pH changes and the bacterial colony and the biome changes. So another way of looking at this, you were having post-coital UTIs, but did you know that post-coital flares are caused by tight pelvic floor muscles? Those might not have been infections at all, pathogenic infections at all. That might have been a pelvic floor flare related to sex. It's possible. You need to have a pelvic floor assessment. Donna says, does breaking through chronic pelvic pain address exercises for tight muscles? Yes, but it's much more thorough than that. It teaches you where the muscles are. It teaches you where the nerves are. It explains the different medical conditions that can happen so that you understand cause and effect. It's filled with fantastic success stories, and it shows how patients treated it. And it's different. Linda said, what are my thoughts on chronic embedded UTI? I don't believe it. Anybody who says every IC patient has a chronic embedded infection is living in a fantasy world. There is tremendous diversity in the IC patient population. If you spend time with other patients, you see it. For some people, IC begins in childhood. For others, IC begins after menopause. If they have the same diagnosis, but are they the same? Hell no. For some people, IC begins after they fall on their tailbone. For others, IC begins while they're going through chemo because the chemicals of the chemo damage their bladder. Are they the same? Absolutely not. Today, we recognize this diversity. And we also have learned from the past. Bladder therapies don't work for the great majority of patients. Why? Because the great majority of patients have tight pelvic floor muscles. It's easy to go, I must have infection, give me antibiotics. We all did that when we were first diagnosed, but the antibiotics don't work and the cultures are negative. And even next generation testing is negative. So I strongly disagree. I don't know a single mainstream IC specialist who believes in chronic embedded UTI. I can tell you what they do believe. What we have found in research is that Fungal infections are directly linked to bladder pain in IC patients. The more fungus, when you think yeast, I mean, how many of us believe that we had yeast infections over and over? We should have had stock and monostat, for God's sake. I used so much monostat in high school for these quote unquote yeast infections, when actually all those yeast infections were spasming tight pelvic floor muscles. I just didn't know it back then. But the sad reality is every single one of us has been over-medicated with antibiotics. And when you kill the biome, you kill the good bacteria that control the fungus. And Candida grows. So you can have a Candida infection inside your bladder. I had one for 2 freaking years. It was agony. Way worse than typical IC pain. I was on the floor from taking long-term Augmentin. The National Institute's Health IC research team has confirmed that. They have found Candida in the urine of some IC patients. Why is that happening? Because we've all been massively overexposed to antibiotics, in my opinion. And there's more I could say on that, but there's too many questions. Okay. I mean, too many people asking questions. And so she feels worse on macrobed with urgency, never even felt if I had a UTI prior. Tell your doctor if you're worse. You got to tell your doctor, because if you had an infection, they need to make sure it's not a drug-resistant infection. Donna said, what is the best way for physical therapy to relax tight pelvic floor muscles? Trigger point release, massage, exercises, or internal? Internal. And trigger point release and relaxing tight muscles. It's the finger on the muscles that works the best. And Mary says here, I only seem to get relief with internal work. Me too. Internal work is great. Debbie says 2 years ago, she lost her mom in a car accident. Never be the same again. You're right. Sandy said, after I push to pee, I get an achy vagina. Is that again tight pelvic floor muscles? Yes, because when you're pushing to pee, you're tightening your pelvic floor muscles. Debbie says, I don't understand how one day you have so much pain and the next you don't feel it. It makes me crazy, but that's muscles. One day the muscle is tight and the next day the muscle is relaxed. The muscle might have been tight because you were sitting for a long period of time. Maybe you took a long car ride. Maybe you had sex. And the next day you're better. Sue says she's recovered from COVID. You push back the service until the 10th of this month. A lot of things, virus going into Michigan right now. They have affected other family members. We have a new niece and a nephew since your mom passed. Oh, okay, honey. So did the funeral happen in March or is it happening in April? Because if it hasn't happened yet, I want to send you flowers. But if it's already happened, I'm sending you my love. Wendy said, sorry for your loss. Okay, I love you guys. Thank you for supporting Sue. Mary says her feet are weird. She lands on the outside of her feet. And her iPhone tells her if her gait is wonky. Who do you see? A podiatrist. Natasha said, I peed blood a couple of times, which is how I knew it was infection initially. But yes, after that, I feel it was just pelvic pain. Okay. Jacqueline said, am I a doctor? No, I'm not. I have a master's degree. I'm an IC support group leader for 31 years. And I'm very clear on that. My job is to educate, inform, open some new doors, and then send you back to your doctor. Natasha said she was in the hospital with IV antibiotics. What was the infection? Jacqueline says she has a catheter for life. Not fun. Why, Jacqueline? Why do you have a catheter for life, hon? You have a suprapubic catheter, like neurogenic bladder, of the nerves in your bladder stop working? Mary said, so if embedded infections don't exist, why do you go for microgen testing? Great question. So they're not the same. An embedded infection assumes that, we call it a fastidious infection sometimes, that you might have a weird little infection like right here or right here, that it's embedded into the tissue. Next generation DNA testing tests urine, and it will tell you by DNA analysis what's floating in your urine. And that's a good way of assessing if you have a pathogenic infection. Because normally, and that's one reason why I just don't support the embedded theory. And I had great pictures of it. I showed them last week from Dr. Scott Holgren's lab. So bacteria start here, okay? So they're going to attach to a cell they can reach with pili, little tiny mini arms, for lack of a better term. So they're gonna let's say they attach to this cell, and we actually have pictures where you can see the bacteria burrowing into the cell. It's like half in and out of the cell, okay? Once it gets into the cell, it converts the cell to a bacteria factory. Takes a couple of hours. Now we got a bunch of bacteria living in this old cell. The cell bursts open, destroys the cell, and those bacteria then float. But then they're going to get to the next cell. And if they come back down and they attach to the next cell, now this next cell becomes a bacteria factory. It ruptures open and bursts open. Then it's going to go here. And so you end up with a tunneling effect. And if the infection's really severe, the infection's going to get through the urothelium down here into the interstitial layer of the bladder, where it's going to affect blood vessels, and it has the potential of causing that bleeding. So, bacteria are parasites. Pathogenic bacteria are parasites. They tunnel through the wall. My understanding of the embedded infection theory is that some people think that an infection can just live here, like in this spot, and it doesn't do anything other than cause kind of low-level inflammation. The problem with that theory, and again, I have said, if I could go back to grad school and get a PhD, I would be getting a PhD in this very topic. Bacteria need food, and bacteria grow. So bacteria can't just park itself in one spot and live there. It's got to eat, and it's got to grow. So it's going to expand in some way. The only time that we have seen that happen, and that again is in Scott Holgren's lab, is that E. coli, when threatened, changes shape. It goes from looking like this to looking like a noodle. It gets long and skinny. And by changing its shape, the white blood cells, your body's army can't find it because it doesn't have the same receptor spot. And so that's one way that E. coli can defeat it being killed. E. coli is very adaptive. The other thing, now this may have changed because I haven't read all of his research in the last couple of years, is that under extreme duress, and again, I might be wrong, this might be updated. I think what they saw is that some bacteria commit what they call harikari. What they do is they kill themselves, but they take somehow a little piece of DNA gets wrapped in a little liposome, and they call it a bacteria seed. And so the living bacteria is dead, but the seed remains, maybe in that one little spot. But the seed gets turned on by your body's healing process. So even that defeats the embedded infection theory. And again, I've been caregiving for the last 10 years, and my time has been very limited, and I have not had time to follow these pathways. I should interview Dr. Holmgren and do an article on it. I just, Scott Holmgren, you can Google Scott Holmgren Lab and look at his pictures. He's got electron microscope pictures of all this happening, and it's just so fascinating to see the white blood cells coming out, and the white blood cells trying to kill the bacteria, and the bacteria changing shape. It's fascinating. Danielle says, Jill, you give me so much hope to live again, or at least to fight. And I have that amazing book by Dr. Weiss. Excellent. Diane said, I take PEA capsule, one PEA capsule with 250 milligrams of Tylenol and 100 milligrams of ibuprofen, and it helps a lot with pain when flaring. Cool. Good. Diane said, is there an info on torn ligament of the uterus causing lesions in the bladder? Yes. It's on our website. I just did, there's a blog on our website, something like an unexpected cure of Hunner's lesions, which was the first case study that came out 3 years ago of a woman with severe Hunner's lesions, and she had a severe prolapse. And when they went in to repair the prolapse, they found that her ligament was broken and her uterus was facing backwards. So when they fixed it, something absolutely remarkable happened after surgery. Her Hunner's lesions healed completely, and she's considered a complete and total cure. Besna says, thanks to your Jill, that is what the doctor said too. He didn't care a lot about polyoma BK. Other doctors also said that more than 50% of the population is infected. So they don't blame the virus for Hunner's ulcers. Well, if you look at, yes and no. So there is a condition called hemorrhagic cystitis, patients who are hemorrhaging from their bladder. Massive, massive blood being released by the bladder. And they have directly linked hemorrhagic cystitis to the polyoma BK virus. And there are studies at the National Institute and the National Institutes of Health and the National Library of Medicine that prove that. So if 50% of the population have polyoma BK, that's fine. The question is, why does it get turned on? And the answer is, it gets turned on in patients who are immune compromised. So some of the best work was done during the AIDS epidemic, because patients who had HIV/AIDS were massively immune compromised. And what you don't know is that they were dying in their hospital bed. They were hemorrhaging out of their bladder because that virus had turned on. So I agree that it's common. I disagree with anybody saying that's not the cause of Hunner's lesions when we have very clear research that shows that the polyoma BK virus causes bleeding wounds in the bladder. And what is a Hunner's lesion? A bleeding wound in the bladder. And during hydrodistensions, Hunner's lesions bleed like a bloody waterfall. So anyway. Garden says, thank you, Jill, for all you do. I'm referring everyone to you. IC 101 is a great book, Taking Lactoferrin and Bladder Builder. Oh, I hope you're doing well, honey. Thank you. Kim says, Jill knows more than most doctors do. The only reason, hon, is that I study it every day. I mean, like, there's really, I might get 1 day off a week right now, which is usually a Saturday. And even yesterday, I had an ant invasion in my family room yesterday. I was quite annoyed. I hate bugs in the house. And I spent hours following a trail of ants until I found that they were coming out of a furnace vent. And then I cleaned that room like it had never been cleaned before. My family room is cleaner than it's been in 50 years. And then I surrounded the heater vent with Dawn dishwashing liquid. And they don't, so that stopped them. But I was just like cleaning, looking at them, seeing them all in the heater vent going, God bless America. And so finally, it's like I could call the pest control company on Monday. But I sleep in that room right now. And it's like, I didn't want ants in the room I was sleeping in. And so I pried off the cover, and I found that there was this little tiny gap that had come open. And so I sealed it back up. And because I couldn't, the Dawn dishwashing liquid smelled so bad, and I have smell sensitivity. I couldn't sleep in there with that smell. And so I had to open it up and fix it all up and then clean up all the Dawn dishwashing liquid so that I could sleep in the room. Hello, central sensitization. It's funny how we have to adapt to things like that. Cindy. Yes, Cindy's just getting over UTI. Still feel like it's there. I had blood work, show high white blood cells and CRP. That's infection and inflammation. No one can tell me why. Well, I mean, Cindy, as Sue said, I mean, I just got to tell you, it's a brutal year right now. I think the colds and flus going around this year have been very, very intense and much more severe than normal. And so maybe you've just picked up an infection that's lingering. I mean, some people have been sick for weeks. Lisa said, is there any evidence for using aloe vera, marshmallow root, or drinking alkaline water? No, only anecdotal evidence. There's not a single published study in a medical journal that shows that aloe vera is helpful for IC. And drinking alkaline water is, in my opinion, more damaging than good because alkalinity is just as bad as acidity. The goal is to be pH neutral. So spring water is your best bet. Drinking alkaline water all day, in my opinion, is a big mistake because that just ends up irritating the bladder too. Marshmallow root is a little bit soothing. It helps some people, but other people flare from it. It's not a big deal. I think the place for aloe is kind of the same place for bladder installation in that it can be a little bit soothing during a flare. But I don't see aloe fixing any underlying problems. And again, there's not I'll look again. Hold on. Let me look again. So I'm going back to the National Library of Medicine, and I'm going to search for interstitial cystitis aloe. Nothing with IC. There's 2 studies, one phytotherapy for uro-oncology, where they talk about phytotherapeutics, and they include aloe with pomegranate, mistletoe, sage, ginger, and ginseng, nothing to do with IC. And the second article is a critical approach to evaluating the clinical efficacy, adverse events, and drug interactions of herbal remedies. And let's see what they say here. On the other hand, inconclusive evidence of efficacy or contradictory results have been reported for aloe vera in the treatment of psoriasis. So nothing. Now let's just do bladder pain, aloe, and let's see if anything new comes up. I mean, 4 results. Multiple life of nerve growth factor, neuroinflammatory implication of schisto infection in mice. Something about the queen of neuroscience, Rita Montalcini, and the last one, evidence that nerve growth factor promotes the recovery of peripheral neuropathy induced in mice. Okay, so nothing. You just have to remember that's all we had back then. 25 years ago, all we had was aloe and Cystoprotect. And when Cystoprotect came out, you know, it was far more popular than aloe products back then, and more so now. We just don't see much use for it right now, other than for flares. Hold on. Mary said, I had Hunner's lesions. They were treated and I believe are gone. Why then would I continue to have pain every day? Well, you could have pain coming from nerves that are irritated, or you could have pain coming from tight muscles, or from other things like scar tissue, things like that. Susan said, hey, Jill, Dr. Evans wanted to take the Unistim out that he put in December because I told him it wasn't working. I turned it off. Do I necessarily have to have it removed? Well, yes, girl. Yes. The longer you keep it in, the harder it's going to be to remove. Get that sucker out. And the thing is Dr. Evans is just a brilliant surgeon. And so, I mean, he was doing the bladder transplant surgeries at Wake Forest. You don't want to leave something foreign in your body because, number one, what happens is your body reacts to that. And sometimes it compartmentalizes that. You can end up with this kind of knob of scar tissue. And that scar tissue isn't necessarily just around the box itself. It can be around the leads. And that just creates a cascade of problems. So if he thinks it should come out, man, follow his recommendation. I mean, he is so highly respected. Natasha said, after IV antibiotics, her culture showed no significant growth. Okay. But you still have problems today, and we have to figure out why. And you need a proper phenotyping. Sharon said, I did a trial with a spinal stimulator about a month ago. I'm having surgery on April 11th because it completely stopped my vulvodynia. That's not what I'm having it put in for, but I was shocked to find that it worked for that. When I asked my rep about it, she said they had just put one in for interstitial cystitis in another woman who had vulvodynia. Okay, so vulvodynia is pain on the vulva. It can feel like a yeast infection, even though there is no infection there. Structurally, that vulvodynia is being caused either by bad skin that's messed up, by nerves that are messed up, or by tight muscles squeezing nerves, or perhaps a blood supply issue. So even estrogen atrophy. So if you're of a certain age and you're in estrogen atrophy, Unistim is not going to fix estrogen atrophy. Estrogen cream will fix estrogen atrophy. So I understand your motivation, but I would also want to make sure you dotted your I's and crossed your T's. And I mean, I'm assuming since you've been diagnosed with vulvodynia, you've had the full workup for vulvodynia. I would just want to know what's the health of my skin and what's the health of my muscles. Because if those are fixable, we want to fix those before doing major surgery, right? I mean, our guidelines can basically say, start with the least invasive stuff before you do surgery. You work your way up to surgery because there are consequences to interstome. There are lots and lots and lots of adverse events with interstome. So you gotta, you can't go into this assuming that this is a piece of cake and easy. It's not. There are risks, significant risks. And you have to learn about those risks. And if there's an easier way to do it, I would want to do the easy stuff too before doing something surgical. All right, let's go back here to YouTube. Okay. Diane says, I'm going to start with a new pelvic floor physical therapist, hopefully on the 9th, because I know I have tight pelvic floor muscles too with the lesions. The new PT is in private practice, so I can see regularly. Good. Good. In the end, rather than looking at this as a quote unquote disease, I think that as you focus on your treatments, you have to start thinking about anatomy more. Is my skin healthy? Are my muscles healthy? Is my bladder wall healthy? Is my central nervous system healthy? Those are all important questions. Sharon says, my main reason for having it put in was because I was hit by a drunk driver some years ago. I have severe back pain and had to sell my business and become disabled due to it. Okay, I get it. I totally get it. Hey guys, time for a quick bathroom break. I'll be right back, okay? I have returned. How long have we been going? Man, 3 hours. It just flew by. You would never know that I was actually feeling a little anxious before I started this meeting. I was just, I did an article on pasta primavera this morning as an icy friendly spring meal because so many people miss pasta. Anyway, I was doing that, and then I was just thinking about, the state of the economy and just worrying. I'm concerned. It took 25 years for me to be invited to participate in a very big federal grant. And I should have brushed my hair, darn it. So this year I was invited to participate in the big Center for Disease Control IC grant a year ago. And this was right as I was being diagnosed with breast cancer. And so I did my portion of it, and we got funded last fall. We got funded. And it's such an honor to be invited. And now I don't know the status of the grant. I mean, I'm just hearing that a lot of the medical research, especially women's health research, is being shut down. So cross your fingers. It's a stressful time. Somebody asked if I was a doctor, and a lot of people think I'm a doctor. I was pre-med. I'll tell you why I did not go to medical school, because I had the chance to go to medical school. I have a really rare undergraduate degree. I have a degree in pharmacology, drug development. And they don't even offer this degree anymore, which is crazy. Only master's and PhD patients can do it. It's really rare disease from the degree from the University of California. And in that degree, I did surgery for a year. Every week, I was a surgeon on animals. And I love animals. And that's why I left that career eventually. But it turned out that I was actually pretty good at it. So much so that the lab director set me up with some fantastic interviews. It turned out, even though it was weird doing surgery is weird. I got to tell you right now, doing the initial incision is gross. But I did it, and I did it really well. What I wasn't good at was anesthesia. I struggled with the math and the dilution. It wasn't natural for me. It just wasn't natural. And I felt that any practicing doctor should have a natural grasp of something that I was struggling with. And so that's why I did not go to med school. I didn't think that was the right place for me. I went into drug research. 2 years ago, I got chewed out by a doctor from Harvard. That's hysterical. She's like, Jill, why didn't you go to med school? You would have been a great doctor. Why didn't you do it? And that's exactly what I said. I said, listen, I just wasn't confident in my math skills, even though I had calculus and all that sort of stuff. It was just hard for me. And she said, they would have helped you. That's why they have tutors. And she just reamed me out, and it was hysterical. It's like, I didn't know. I thought I was making the best decision because I didn't want to hurt anybody. And my lab partner became a brilliant pediatric surgeon. And so I had the goods. I don't know. I was worried that I wasn't good enough. So that's why I'm here. But, I can still do research and all that sort of stuff too. It's quite an interesting story. Sandy said, my urologist said my bladder urge to pee is from my IBS gut issues. He said tight pelvic floor causing gut and bladder issues. Yeah. Well, because if you have a tight pelvic floor, then they're squeezing nerves and they're restricting blood supply. Now you have neuroinflammation, and that neuroinflammation spreads. We call it the pepperoni pizza algorithm, and this was a research study from like 20 years ago. They were able to prove that if you irritated the bowel, the bladder would show signs of irritation, and if you irritated the bladder, the bowel would show signs of irritation. And that's what helped us understand that the nerves are actually connected up in the spinal cord. And I have a book that has a great picture. Hold on. Let me see if I can find it. Not there. Not there. Not there. Well, it's somewhere. Anyway, imagine like this spaghetti bowl of nerves that all merged up into one nerve right in the spinal cord. And the other thing they did that was so interesting is they put radioactive tracers in different nerves. So they'd have one, and I did radioactive tracer research. Oh my God, talk about working with radioactivity is crazy. So they put one tracer in the nerves of the bladder, one tracer in the nerves of the vulva, and one tracer in the nerves of the bowel. And they were 3 distinct tracers, and then they followed them, and they all merged at one point in the spinal cord. And that's the underlying theory behind what we call neural crosstalk. Maria says, I think I would have too, to be quite honest. I was just very young and immature. And Sandy Gastro said nerve sensitivity. Yeah, that's the epitome of nerve sensitivity. It's a nerve sensitivity spreading. It's a neuroinflammation spreading along all of the nerves that go to that part of the spinal cord. And so all the nerves show inflammation and then sensitivity. I've come to see that, it's interesting as you get older. When you're younger, you have to prove yourself. And how do you prove yourself when you don't know who you are? I just remember, because again, I'm a victim of childhood trauma. My life has been dominated by anxiety and fear. Just flat out. And in my brain, I'm still that little girl running from the guy who hurt me. And I did not understand the toll that would take on my life. And I was thinking this morning, I was gonna write an article on what are the 10 things that I've learned about or what were the 10 things that I would do differently. And the very first thing I would do differently is I would have gotten extensive therapy when I was a kid for what I went through. I mean, you guys, I grew up in a neighborhood with a kid who became a rapist or murderer. And I was one of his favorite targets. I did not leave my house without fear for a decade. And I ran to school as fast as I could, and I ran home as fast as I could. Because I never knew when I was going to get hurt. And I was hurt many times. And the hardest part is that I was isolated from everybody else. Because no kid would walk with me, because no kid wanted to get attacked. And so it was Jill against the world. It's Jill against the world. And in my brain, that's my identity is being alone and fighting and having to do it all by myself. Oh, and if I could go back and do it differently, I just really wish that I had gotten much better care to deal with that trauma. Because I realize now, that it stopped me from doing important things that I could have done. I used to dream of being an astronaut. When I was in high school, people asked me what I wanted to do. I wanted to own a patent, which I still want. and I wanted to be an astronaut. And I actually interviewed at NASA, and I turned down the job. But I just regret that. I think that now working with patients, and now that I see for those of us with widespread pain and anxiety, the childhood trauma is it's played a giant role in our lives. And I think it's really easy for family members and professionals to kind of look at you. Are you okay? Yeah, Jill's okay. And walk on, not having an understanding of that Jill was profoundly damaged. So much so that her central nervous system virtually shut down. I ended up with all the related conditions to IC, along with terrible anxiety disorder from being attacked. And I was invited to a meeting in North Carolina to work on the IC guidelines, and I said no. My brain says no. Now I said no. My immediate reaction is always to say no, because that's that's my brain trying to protect me. But the real reason I said no is I can't afford it. I just can't invest that money right now, because I would have to pay for all that travel and everything. And I can't do that right now. But I just grieve over my lost opportunities, and more so the lost opportunities of the many, many patients I've worked with. And it's such a blessing to be able to say to patients, this is not your fault. You've done nothing wrong. This is about how a child's body responds to and adapts to trauma. I have a very good friend, and he was attacked as much as I was, if not worse. He won't even come to my city. His experience was much worse than mine. And then I ran into another guy that I grew up with who said, oh yeah, he shot me. Renee says, same for me, or years of it. Widespread pain, stayed in fight or flight, still have to battle it. I grieve too. But then this quote here, we are not designed to heal if our body is in fight or flight. And that's why I'm so much better now. I blame my improvement, number one, on the fact that I learned exceptional anxiety management skills in my 30s. And I embrace these, and I use them daily, and I focus on my central nervous system, and I exercise a lot. I walk a lot. I know that my mental health matters. I just, if I could go back in time, what would I do differently? And I think I think that I should have had a lot more support. I begged my parents to take me to another school. They refused. That was, I think, a horrific mistake. I should have been allowed to go to another school. But, here's the deal, is enough. Listen, once you fought breast cancer, as I did last summer, I'm a completely different woman now. It's like, listen, I got maybe 20, 25 years left. I don't want to live with anxiety anymore. I don't. And I immediately signed up for trauma therapy. I was seeing 2 therapists last fall, and I'm so glad I did, because I feel better. I feel so much better now. And I really understand. I understand the entire sequence of events now. And I know 100% never my fault. And it's not your fault either. And that's why I always say that to patients it's like one of the very last things I say whenever I work with a patient on the phone. It's not your fault. You've done nothing wrong. And we have control over our life right now. What happened to us as kids, it's over, it's done, it's not going to happen again. He's in freaking jail. I'm capable of defending myself now. You are capable of defending yourself now. And if you grew up in an alcoholic home, which is what we see a lot, I didn't, but a lot of IC patients with central sensitization did, it's, you're safe. It shouldn't have happened. I'm sorry that it happened to you. I'm sorry that it happened to me. We grew up with trauma. But what we have to do now is tell our brain we're safe. We have to get our brain out of fight or flight, and we can do it. We do that with good mind body medicine. I do lots of, we can turn fight or flight off in 5 minutes. Easy. If you want to call me and learn a technique, I'm happy to teach you a couple of techniques that I use that are fabulous. I just think that the challenge that we have is that the world is just horrifically stressful right now. I don't know anybody who's not stressed. It's just a tragedy what's happening right now. And to think that he said he would consider military action to take over Greenland. What the fuck? I'm sorry for swearing. We don't need this level of stress. And that we're worried about our Social Security now and all that sort of stuff. So, one day at a time, keep your home your safe place. Get off of social media in the sense of don't remember they make money by keeping you upset. They're going to say whatever they can to keep you engaged. If you love them, if you hate them, if you're this, if you're that. Social media is poison right now. You're right, Renee. I agree. But hey, man, that happened yesterday. Interview. So I just think that right now we're in a survival mode. We're in we don't have the ability to change what's happening other than in our lives and in whatever modest protest you might want to do. But it's a crazy time. It's a crazy time. I want you to look at me as a safe place. I want you to feel welcome. I will never ask what your party is. I will never ask what your religion is. I will never ask what your sex is. I simply don't do that. If you're struggling and you need a shoulder, call me. I would love to help you. As my grandmother said to me years ago, you have to earn your angel wings. This is me earning my angel wing. And if you like what I do, if you like these meetings and you like having a place to come gather, come on over to the IC Network and become a member and get our magazine. Because honestly, that's where I do my best work, is in our magazine. How do we heal while we're in survival mode? Well, that's a problem. It's really hard to heal because your body is spending its resources trying to protect you by keeping you in fight or flight. And so this is where we have to get out into nature. We've got to do our mind-body medicine. We've got to do really specific anxiety management tips, just doing basic deep breathing and just I call it the pink bubble technique. This is something I learned when I was getting my master's degree in psychology. And we did it for children who had nightmares. And so if you have a child who has nightmares, if they're in bed, what you do is you have them close their eyes and imagine the bed is covered with a big, giant pink balloon. Has to be pretty. And if it's for a guy, it can be camouflage, whatever. Just a big balloon. And they have total control over the balloon. They can let whoever they want in, and they can keep whoever they want out. And show them that this balloon protects them when they sleep. And that's just kind of something that I practice every day. It's like my home is surrounded by a pink balloon right now. And I just think that we have to make big changes. And I think that that balloon, you have to have that balloon across the internet. I mean, I know you're watching me on the internet. And I mean, I started the very first IC groups online 30 years ago. But the internet today is not the internet that it was back then. It's very different, and it's very harmful. It just is. It has moments by keeping everybody upset. It's like a dripping source of poison in our homes. So I don't know, I just long for the days when after dinner the kids went out and played kick the can while the adults had a glass of wine and sat on the porch and talked about their day. You know, I mean, that's like the life I want right now. And the other thing that I have been doing is I'm just watching old stuff on TV that makes me feel good. Although I watch a lot of, you know, I prefer British stuff, British mysteries and stuff like that. But I'm just trying to watch comedies and trying to keep myself off of the internet. It's hard because we all get addicted to the dopamine, you know, it's like, and I even find reading hard because I can read for about a half an hour and then my brain goes, hey, watch a video. And I'm annoyed by that. Lori says cognitive behavioral therapy helped me a lot. Yeah, it helped me too. Really helped me too. In fact, I'm going to have 2 more appointments. I've got an appointment on next Friday. And and EMDR therapy has also been quite interesting. And I feel better. I feel more balanced. I don't feel like I'm being held back by anxiety like I was. And I see that I have control now. And I see that I can make choices now. And that's the start of a new 20 years, you know? Cindy says you're an overcomer. You're making a huge difference with IC. Don't let that man define who you are and who you become. No, but I mean, I've forgiven him. You know, I mean, honestly, he grew up in a severely alcoholic home. I'm sure he was born with fetal alcohol syndrome. It's not that he doesn't define me in any way, shape, or form. It's just that what defines me is running alone. Just feeling like I just had to run alone. That's what defined me. And I still struggle to change that. I really want to change that. I have been changing that. But I still, my identity is still this little redheaded girl, you know, who was hurt and alone and looking for somebody to help her, and nobody came and helped her. You know? But I'm perfectly capable of helping myself. Hey man, you know, like I will talk about anything. I'm not interested in hiding stuff. I think it's really important because I know, because I talk with you, that there are many patients out there who share my experience. And I just want you to know, no shame. It's okay to talk about it. As long as we're working forward. We can't live in the past, and we also can't fear the future. What we have right now is today. What can we do today to feel better? What can we do today to improve our brain health, to improve our physical health, to give us some comfort and grounding? And so I every morning I wake up and ask myself, what can I do today? Today is a new day. It's a good day. Thank you. Thank you. All right. Well, we've been going for 3.5 hours now. I'm here as long as you have questions. I mean, obviously, I'm willing to talk about just about anything, but let's go ahead and see if y'all have any more questions. Stretch. Stretch. Ow. Ooh. Ooh. Hello. Hello, mastectomy scars. Sandy said, after I pee and poo, getting stomach spasms from IBS and IC and tight pelvic floor. You know, Sandy, so when my IBS was really bad, okay, and remember, the connection between all these conditions is the central nervous system, right? Okay. I would get, after having a bowel movement and having IBS, I would get a wave of nausea. And also, like, sometimes even a little wave of dizziness that I associate with the vagal nerve. And I had many periods of gastritis where, in addition to the IBS, I would just have terrible stomach problems too. And I will tell you that they're all gone now. But one of the things that was really, really important for me personally is accepting the fact that, hello, we're sensitive, and we all have different food sensitivities and food intolerances. I know from like the age of 24 to 28, 29, my IBS was out of control. I mean, it was really, really bad. And I had what I called bend over and screamers every morning. I mean, just like 10 or 11 o'clock every morning, bam, I was in the bathroom on the floor. And the spasming was so bad I could barely walk. And when I went to the doctor said, hey, this is IBS, you just need to eat fiber. And so I was eating a ton of oatmeal. So I eat oatmeal. So believe me, I ate oatmeal. I had oatmeal in the morning. I sprinkled oatmeal on my salads, you name it, I did it because I just wanted to get better. And you know what? I got worse, a lot worse. And then finally, my sister gave me a book on food allergies and food sensitivities. And I think I have it. Yeah, here it is, right here. My sister gave me this book 40 years ago. And it was life-changing to me because it introduced the concept. It was published in 1981. It introduced the concept of a food allergy versus a food sensitivity. So an allergy is something that provokes an allergenic response that would make your throat swell and potentially even kill you, like a bee sting, or if you have a child that's allergic to peanuts. That's a really big life-threatening allergy. Well, I wasn't having that. What I was having was a sensitivity reaction. And a sensitivity is almost like your body doesn't know how to process it, so it considers it poison. It's almost, I mean, that's the layman's way of describing that. All I knew is that when I ate oatmeal, or the other trigger for me was chocolate, wherever it was in my gut, it spasmed. So if it was in my stomach did this. When it was in my bowel, it was doing that. And when it hit my large intestine, the spasming, I could feel it moving from my right side to my left side, and then down my left side and down to my rectum. And the worst pain of all was right, like in the 2 inches before my rectum. That was the bend over and screamer pain. So it's like my bowel was just quivering in agony because it was interpreting it as poison in some way. I mean, that's just the only way I can explain it. So anyway, this book the first thing it said is stop dairy. And I'm like, I had already done that. I mean, I could tell that when I ate dairy, the cramps were a little bit more intense back then. So I had stopped dairy. Then the second thing the book said is stop all grains but rice. And I did. And the next morning was the first morning in years that I did not have a bowel spasm. I was like, well, that was weird. And then the book said, reintroduce the grains one at a time. And so I introduced wheat and I was fine. I introduced corn and I was fine. I introduced oatmeal. And guess what happened? The next morning, I was laying on the bathroom floor again. It turned out that oatmeal is a trigger for me. And then, ironically, hello, I'm Norwegian. There's no oatmeal growing in Norway, at least not that I know of. So my body legitimately has no idea how to process oatmeal. It literally is kind of like a poison. And then it had other suggestions to it. And one of them was I started doing avoiding diary, and then I saw, whenever I ate chocolate, that happened. And so my big food triggers are chocolate, oatmeal, and for my stomach specifically, leafy green vegetables. I eat a ton of salad. I just don't eat lettuce or spinach. And I'm way better for it. Because it turns out I have a little bit of gastroparesis. And as long as I follow that, I'm fine. So it sounds like, Sandy, that you're going through what I went through. And I would encourage you to start doing a food diary and track your symptoms. Just track your symptoms. And then if you have a bad day, look at what you ate the day before. And let's see if you're having that same food sensitivity reaction that I might have been having. Or they have a new blood test called an ALCAT test, ALCAT, where they can take a sample of your blood and then they introduce the most common foods to figure out what you might be reacting to. That would be interesting. So you say you eat good, but it happens on vegetables. So you might have some gastroparesis going on. It's interesting. Mary says, can I explain gastroparesis? Gastroparesis is delayed stomach emptying. It means that the nerves in your stomach have slowed down, and I think in some cases become more sensitive. And so I was diagnosed with gastroparesis in my 40s. It hit one day, I remember I was at the gym on the Stairmaster before I knew about the pelvic floor, and I started belching. My stomach felt full and I had to belch. And over a period of weeks, it got worse and worse and worse. I think it started in like September. And by my dad's birthday on November 11th, I couldn't eat and I couldn't even drink water. And I ended up in the hospital, admitted. And I had this just terrible stomach issue going on. And they discharged me the next day on his birthday. I felt so guilty. And then finally, like 6 weeks later, they did a gastric emptying study, and they found, and I had another test at 4:00 in the afternoon. My breakfast, my scrambled eggs that I ate at 8 a.m. were still sitting in my stomach. And so I had a formal diagnosis of gastroparesis. So what they can do is there's a medication called Reglan that they prescribed to me that gets the stomach moving again. But it's a dangerous medication. And about 2 months into it, my tongue started vibrating and I couldn't talk. And it turned out that Reglan is associated with the permanent tremors. And so once my gastroenterologist heard that I was having trouble talking, and he like yelled at me, "Stop the medication immediately, and let's hope it's not permanent." And thankfully, it wasn't permanent. Otherwise, I wouldn't be able to do this meeting. So instead, the other advice for delayed stomach emptying is you can't eat foods that are hard to digest. It's important that you give your body foods that are easier to break down. And so the biggest trigger for me was leafy greens, because leafy greens are hard to digest. And so I knew that once I stopped the leafy green, I mean, I eat lots of salad. I eat carrots and peas and cucumbers and beets. That's fine. I just don't eat lettuce, and I'm so much better for it. And I even tried to eat like a spinach souffle, where it's all ground up. I had terrible gas in my stomach hours later. Sometimes they have you peel the skin off of apples, and you don't eat a lot of raw vegetables. I eat a lot of cooked vegetables. I'll eat carrots raw, I'll eat cucumbers raw, I'll eat peas raw, but I don't eat celery raw. I just try to keep, and then the other big thing is small meals over time. And that's why I closed the IC Network office and moved my office back home, was because when you have active gastroparesis, you just can't, you can't eat a hamburger. You can't eat half a hamburger. I was down to eating like 2 bites of a hamburger. And so for several months, it's like snacking little tiny snacks all day to try to get food in you. And now it's mostly gone, and I can eat again. But if I eat the wrong foods, I will get messed up. Sandy said, I looked up IC. It says after peeing, you can't get stomach spasm, nausea from IC inflammation. I'd like to see what you're looking at. If you can give me a link, I'd like to look at that. Stephanie said, Marcaine is an installation. Initially makes me feel like I don't have IC, and minutes later I have extreme pain. Only happens with Marcaine, never with licaine. That means Stephanie, that means you're intolerant to Marcaine. Some people are intolerant to lidocaine. Some people are intolerant to Marcaine. They're different. Lidocaine is a short-term anesthetic. Marcaine is a long-term anesthetic. So your body just doesn't tolerate it well, so you're done. I'm sure your doctor has said that to you, right? That if you have that extreme reaction, then it's probably not the medication for you. I guess the other question is, how long does the pain last? When you have that reaction, how long does that pain last? Diane says, okay, we did that one already. Trisha says, I've been so appreciating your videos. I've recently been going through severe GSM, genitourinary syndrome of menopause with estrogen atrophy, and I'm finally feeling better after 3 months of vaginal estrogen. Yeah, baby. Yes, excellent. That's what I want to hear. That's great news. Kim says, I don't have a gallbladder and I have to watch everything I eat. Girl, me too. That's the new thing. I had my gallbladder removed exactly a year ago, and I cannot eat saturated fats. Just can't do it. I cannot eat egg yolk. There's something called bile diarrhea that happens. If you don't have a gallbladder, there's no place for it to go. So it dumps into your intestine, and it turns out bile causes diarrhea. And the most bile that's produced is when you eat a saturated fat. So I don't eat butter. I don't eat cream. I don't eat dairy. I don't eat eggs. I don't eat red meat. And I don't eat cheese. And it sucks. I would love to eat cheese, but bile diarrhea is different. It is a force. And you're stuck near a bathroom. And just when you think you're done and you're out trying to do things, it comes back. And it's better to just loose the fats. Kim says, oh yes, good old bile D. I mean, if you know, you know. If you've had your gallbladder removed, then you know. And they always say, oh, it'll get better with time. At least for me right now, if I have to go do anything, I just don't eat until I do it. Like all I've had today is cereal. I had Ezekiel cereal this morning. And then I had warm water. Why do I do that? So that I don't have to run to the bathroom during these meetings. Cindy said, oh, let's see, hold on. Diane said, oatmeal is a problem for my IBS too. I'm Norwegian and Danish. See, Diane, I'm telling you, I think it's genetic for us. I do. And I am 100% Scandinavian. I've got all of my ancestors are Scandinavian. Like I am as pure blood as you can be Scandinavian. And I have cousins in Norway right now. And yeah, all of my grandparents were from Norway and Sweden. I was even looking at citizenship because I can become, based upon that, I can become a citizen of Norway or Sweden if I wanted to. Kim says she's 14 years post gallbladder removal and she still watches everything she eats. I can see that. My sister had her gallbladder removed a few years ago and she's exactly the same way. Cartsy said, welcome to a plant-based diet, Jill. You're going to live a long time. Sorry you lost your gallbladder. I think the hard part is I had no clue. My mother had her gallbladder removed. My sister had her gallbladder removed. I had no idea that I had a bad gallbladder. All I can tell you is that Gaviscon was a friend of mine. I hardly use it now. And then one day, like 4 months before my gallbladder basically did its thing and ended up with me in an ambulance thinking I was dying, I had eaten dinner and I had terrible stomach pain. And I came back to my bedroom. My parents were in the kitchen and the family room watching TV. And I was in my bedroom, bent over. And I swallowed like 12 Gaviscons. I mean, it was that bad. And I was thinking, I've got to call an ambulance. This is really bad. And then I felt something pop and it went away. And I realized it was a gallstone that was stuck. So that was that only happened once. And then, 4 months later, my chest, I just had this sudden exploding pain out of my chest. And I thought I had a blood clot from COVID in my lungs or in my heart. And I was so ill. I would have driven myself to the ER. I couldn't do it. I had to call 911. And it turned out that my gallbladder was completely blocked. And they were very impressed. They went, these are the biggest stones we've ever seen. It's like, you want to see it? I'm like, no, take it out. There, the surgeon came in. She's the one who did my mastectomy. And she looked at me and she said something like, you ready to get rid of this? And I went, yes, take it out now. And it took a day. I was in the ER for like 20 hours before they could schedule me. And anyway, Renee says, how long does it take for the estrogen cream to quit burning? A couple weeks usually. I mean, I would think within 2 weeks would be much, much better. If it's not, then I would suspect that there was something in the cream irritating you. Like if you're using Premarin or Estrace, the brand names, they tend to have a lot of preservatives in them. And some patients react to the preservatives. So you can go to a compounding estrogen cream, a compounded estrogen cream where they use a preservative-free, a propylene glycol-free base. And so there's always a chance that you might be having a reaction to a chemical. Really good compounding pharmacies will have a number of different bases that they can try, and they can send you little samples. And they can even put it in Vaseline, a petroleum jelly. They can put it in aloe. They can put it in olive oil. They can put it in a lot of different things to try to find a base that would work for you. I get mine from the former Women's International Pharmacy, and it was my OBGYN who said, hey, we already know you're sensitive. We're not even going to try the brand names. We're going to just do a compounded cream from this pharmacy in Arizona. And I've used them ever since. Maria says, is bladder pain a symptom of GSM or just urgency? I definitely have vaginal dryness and irritation along with bladder pain. They all can all be symptoms of estrogen atrophy. I was working with a patient last week or the week before who was almost in menopause at the age of 38. And it turned out her mother went into menopause very, very early in her 30s. So if you've got vaginal dryness along with the bladder pain, then yeah, you definitely want a doctor to look at the quality and health of your skin. Vaginal dryness, I mean, dry skin has a very distinct look. You won't know the difference. They'll know the difference. And if they're seeing estrogen atrophy, then girl, you're 43. I started my perimenopause at 45. And I guess the other question is, are you starting to show some of the other symptoms of perimenopause, like more anxiety? I had a lot of free-floating anxiety where I would wake up scared. I had a lot of muscle cramps. But the defining symptom for me was anger. I just had sudden moments where I just got so angry I wanted to hit somebody. And I asked my doctor why, and he goes, hormone swing. And he was right. It was a hormone swing. So being really easy to anger and being really easy to cry, both of those are clear signs that you are entering now the next phase of life. And the only advice I can give you, I mean, we have a great book called The Menopause Manifesto by Dr. Jennifer Gunter, really good to get. Please understand that one of the things that happens with menopause, many women develop high blood pressure. And the reason why they do, why I did, is because our body loses its ability to process sodium well. And so when they talk about cardiovascular issues with menopause, that's the underlying, one of the underlying factors there. And so be aware of that, and you might want to cut back on salt. I was shocked when I was diagnosed with high blood pressure. I've always been the calm port in the storm. I'm still shocked that I have it, but I use medicine now. And then also too, the other thing that I would really encourage you to do is just start getting facials regularly. You know, this whole, the skin right here thing. Oh my God. Like one moment it's flat and the next moment you've got alligator skin. And it's like, how did that happen? It's so annoying. And if I had known, I mean, I put sunscreen here. I did not put sunscreen. I mean, I put sunscreen here and I put sunscreen here. I didn't put sunscreen here. And I should have. So just like work on your skin. Try to get your skin as healthy as you can. What am I drinking? Now cold lemonade. Yes, I can drink lemonade now, diluted. I don't drink full strength lemonade. I do drink diluted lemonade every day. I didn't do it for 30 years. Used to flare with lemonade. Don't flare at all now. Why? because my bladder is healthy and my muscles are relaxed and I have good blood supply. So my bladder's fine now. I can eat almost anything. I had tomato-based pasta last night. Slept fine. Go figure. Who knew? And again, bladder therapies did nothing for me. What worked for me was pelvic floor physical therapy. When we got my muscles relaxed and released, everything got better. Maria says, the doctor said she saw vaginal atrophy. I guess I need a little hope, believing that the vaginal estrogen will help the symptoms. Yes, it will, honey. It will. It will. You know, think about what happens when you put a raisin in a glass of water. It plumps up and looks like, looks good again. Well, that's what happens to these dry cells when you give them estrogen. They plump up, and more importantly, they start to produce mucus. But let me show you a couple of things. I have a couple of suggestions here. Okay, so here's the thing. You and I are never going to have a 20-year-old bladder again. You have a 43-year-old bladder. I have a 64-year-old bladder. How the hell that happened, I don't know. I can't believe I'm that old, but I am that old. And so there may come a time when doing something that will kind of give your bladder a little bit of extra protection might be really valuable. And so in the old days, this was estrogen. Elmeron, because Elmeron, as the slide showed, this is an old Elmeron slide, right? The way they modeled this is that it's like a chemical Band-Aid. But now we know that Elmeron is linked to, devastating eye disease. And so Elmeron kind of off the charts, but for most patients, they've just moved on. Okay, so what else do we believe have a coating effect? Chondroitin, because the bladder wall has chondroitin as one of its structural components to it. And so it was Dr. Theoharides years ago who created the first chondroitin-based supplement called Cystoprotect. And and this was like 25 years ago, he had a study of over 250 patients who used it for 6 months, and they did well. They had a significant improvement in their pain and discomfort. And in fact, in his study, the patients who had the more severe symptoms responded the best. And so that was the moment when we turned away from aloe and we went to chondroitin. But we now have newer chondroitin supplements that are, in my opinion, just more dynamic and more effective. The top supplement on the market, in my opinion, is Bladder Builder. So it's got chondroitin as a coating for the bladder. It's got quercetin as an antihistamine. It's got a little bit of beneficial probiotics for the bowel, but the single most important difference with it is it also has PEA in it. Hello, PEA, to calm nerves down. And the PEA-IC study was exceptional. And so Bladder Builder was the first supplement that not only helped to coat and soothe the bladder, but it also calmed nerves down. And so this is, many patients are using this now with great success. We did a follow-up study with it a year after it was introduced, and 60% of the patients who tried it just loved it. They reported fewer flares, less frequent flares, less painful flares, and some were pain-free, which we expected because we already had the PEA study. So if you are continuing to struggle with a lot of bladder wall discomfort, you could do something like that. But you also have to understand that because you are in atrophy and your bladder doesn't have this thick coating of mucus anymore, diet is really important for you, Maria. Very, very important for you. Right now, your bladder cannot defend itself. This is not a disease process. This is just dryness. and the dryness is internal. The dryness is in your urethra. It is in your bladder. You don't have that nice thick coating of mucus that you need. And so your bladder's open, wide open to irritation. So this means you really got to control the acids and the alcohols and the caffeine. So no coffee, my friend. If you're going to do coffee, do Dandy Blend herbal coffee or a real low acid coffee. We have Bella Rosa coffee in the IC Network shop, which is real coffee, very, very best low acid coffee on the market. Okay. No tea, no green tea, no matcha. But you can do chamomile herbal tea, peppermint herbal tea, and probably rooibos herbal tea. Although rooibos in quantity apparently got to be careful if you do a lot of rooibos. I don't remember. Somebody sent me a link to research with that. I might have 1 cup of rooibos every couple of days, so that's fine. But if you did a lot of rooibos every day, there was something associated with that. I just don't remember what that was. No citrus, no tomato right now. Think about the acid in a cup of tomato sauce. I mean, that's a lot of acid from a dozen or more tomatoes that have been cooked and reduced, all in that 1 cup of tomato sauce on top of your spaghetti. So it's about quantity of acid. You might be able to get away with a slice of tomato on a sandwich because there's only a little tiny bit of acid there. But a cup of tomato sauce has a lot of acid in there. So over on the IC Network, we have a wonderful food list. We just updated it for the first time in a decade. It's free, it's downloadable. So you want to look at that for some food choices. And your job is to create an environment that will help your bladder heal. Because your bladder's injured right now, and something injured it. And so, does this mean you can't ever drink coffee again? No. I mean, I'm drinking lemonade right now. But what it does mean is that you have to follow the diet for at least 3 months or 6 months, and then slowly introduce the foods back because it takes that long for your bladder to repair itself. It takes time. The bladder is the slowest healing organ in the body. And if you have a cup of coffee every day, it'll never heal because the acid in that coffee is going to destroy that entire generation of stem cells. So you just have to you can't say to yourself, I'm not going to let IC rob me of something I love. I'm going to have my coffee and damn the consequences. Instead, you have to go, oh, gee, I have a wound in my bladder. Does it make any sense to pour coffee on a wound? No. Think about it that way instead. Kim says, my vitamin D was low. Now I need to work on getting that back up. Yeah, mine was low too when they tested it 10 years ago. So I take vitamin D several times a week. I also take B12. Cindy said, what was the name of the pharmacy I use? It was called the Women's International Pharmacy, and their URL is women'sinternational.com, but they have a new name, and I still use them. They just changed their name. It's called the Belmar Pharmacy. I regard it as one of the best compounding pharmacies in the country. I mean, again, it was my doctor who suggested them to me. They're renowned for creating compounded formulas for people who are sensitive. Man, we've been going 4 hours, my friends. This would explain why my neck is starting to hurt. Because I've been sitting here for six and a half hours. So I think we're probably at that time. So let's do this. Last call for questions. Last call for questions. Don't think my neck has another hour in it. I think I'm going to have to go get a heating pad and sit with my neck. Last call for questions. Last call for questions. So I'm kind of back to doing support group meetings for Facebook on Friday nights or Thursday nights, depending upon what my schedule is like. I like to drop in and help. What's happening this week? I am working on a new flare guide and our new diet guide. I just have a massive amount of work to do. We transferred our website. Our website now lives on a new server. Very excited to have that done. That's always very, very stressful. I'm just changing things up a bit. All right, last call for questions. Any more questions? If not, for Facebook, I will either see you Thursday or Friday. And for YouTube, I will hopefully see you next Sunday. Knock on wood for all of these. I might start doing meetings on a weekday night on YouTube if that's something that you think might be interesting. Or we can go start a meeting on Instagram. And my goal in doing these meetings is I think it's very important that we have a seasoned expert support group leader doing meetings. And because there's just so much poor information online. I want to be a source of good information online. So anyway, well, all right, my friends, be well. Always remember that this is not your fault. I don't want you carrying any shame or blame. I want you to have a fantastic week, and I want you to fill it up with laughter. I want you to watch something funny tonight. The body heals when it's happy and laughing. So don't watch a scary movie. Watch something funny. All right, my friends, I'm going to say goodbye to YouTube first. If my mouse is working. Oh, my mouse is barely working. Come on, mouse. As I move my mouse to my pant.